Hello, good evening, everyone. And it's a great pleasure to welcome you all for the second Changing Outcomes in Sphere of Gastrointestinal Cancer. It's a pleasure to welcome you for these 2 days webinars for today and tomorrow. Uh, the organizing teams have a pleasure to welcome Dr. Satya Dattatreya, Chief Medical Oncologist at Soumya Hospital, Hyderabad. And we profusely thank to the scientific committee with Dr. Bharat Vaswani, Senior Consultant Medical Oncologist and Hematologist at Vishoda, Dr. Anand Ramaswamy, Associate Professor at Department of Medical Oncology from Tata Memorial Center, and of course, we have Dr. Viraj Lavankia, Consultant Medical Oncologist, GI Services at SCG Cancer Center, Ahmedabad. Very interesting webinar, and it's a pleasure once again to welcome Dr. Satya Dattatra for his welcome and introduction. Good evening to you, sir. The stage is set for you. Over to you, sir.
Thank you so much, Tarun. A very warm welcome to one and all. We all know that yesterday was the World Cancer Day, and the theme this year has been to close the care gap. I think one of the most important ways all of us can come together to close the care gap is to associate for all such conferences so that in the sphere of GI cancers, in this particular conference, it's the second of its type, where we look at changing outcomes and make sure that the latest and the best is available to our patients. So we need to realize the problems, and then afterwards, we need to find out collective solutions to those problems, and finally challenge those in the top to make sure that these solutions are accessible to all. And that's what the World Cancer Day stands for. Over a period of 3 years, we plan to impact and change the impact that cancer has on our cancer afflicted patients. I would also like to specially thank Dr. Naresh Somani sir for being the guiding force behind the convening of this second GI Cancer Symposium. We recently had the GI ASCO, and I'm sure multiple interesting updates will make us will give us some important practice changing take home messages. Having said that, the organizing committee, scientific committee, has been working day and night with me, and I profusely thank Bharat, Viraj, and Swami for making sure that the whole program is streamlined well to educate all the attending delegates, including the residents, the students, my colleagues, my seniors and juniors alike. So without much ado now, let's go ahead and start the conference with the first speaker for today being Dr. Prasad Narayanan, a very close friend and esteemed colleague of mine from the Site Care Hospital, Bangalore. He is the lead chief medical oncologist there and has a keen interest in immuno-oncology. And to set the ball rolling, therefore, he'll take us through the role of immune checkpoint inhibitors in esophageal cancers or esophageal gastric junction cancers. Prasad, over to you. A warm welcome to you. We're all eager to listen to you, as we all is an excellent speaker, and we learn a lot about how to use ICPIs in esophageal cancer. Thank you so much.
Good evening, and thanks, Satya, for this opportunity. It was a pleasure to actually go through this data and give this talk, actually. So you said that the theme for the World Cancer Day is to bridge the gap. I think one of the gaps that we need to bridge is the differential approach we have towards different cancers itself, from medical oncology. So bridging the gap could be anything, closing care gap. When we have a GI symposium, esophageal cancer used to be the one which had the least importance when as medical. Most of our talks used to be based on colorectal cancer, because that is where we have a lot of data. And then we have the other GI malignancies, and esophagus takes a back step. So let us see how esophageal cancer treatment has improved and how immune checkpoint inhibitors have come in vogue. And another gap is to actually differentiate among the different the esophageal cancer, squamous cell versus adeno. So this is an interesting data which I went through when I was researching for this talk, that we always pool together the adenocarcinomas and the squamous cell carcinomas and the G junction tumors in. This is a part of most of the trials as well, but they are distinctly different in terms of the molecular structure. If you see, this is it's total different way in which the CIN or the MSI or the EBV data is there in the adenocarcinoma of the esophagus or in the G junction, and when it comes to squamous cell. So mostly my talk will be focused on the squamous cell, because I know that in the program we have G junctions and gastric being taken separately, and Viraj is also speaking specifically on the G junction and gastric cancers with immuno-oncology. So why we should separate out the squamous cell cancer of esophagus? This is a pooled analysis from 3 randomized controlled trials, which just looked at the results just based on squamous versus adeno. Something similar to in esophagus, something similar to what we used to do in lung cancer before. And there is a definite difference in the outcome just based on histology. So definitely squamous cell cancer of esophagus needs separate attention. Now, if you take the recommendations of treatment, the first line treatment, of course, is chemotherapy, and the recommendation is a platinum plus a fluoropyrimidine combination, which most of us use in the first line in esophagus. And there are other recommendations as well, like irinotecan or paclitaxel or docetaxel. How we go in the second line, the highlight will be the approvals for pembrolizumab and nivolumab. And my first part of the talk will be how these approvals came in the second line. And then we will go to some of the newer data, the changed paradigm, the present approval which has come with the data. The checkmate data just got published, I think, this week in NEJM, and the keynote 590 data where immunotherapy has come in the first line. So to take you through this treatment, to this talk, we'll start with the third line, fourth line immune checkpoint inhibitor studies. So Attraction 2 trial, the trial which was exclusively an Asian population, third line setting, placebo versus nivolumab. And we had response rates of 11%. If this, when you put this in perspective, when this trial would have been presented before and we have talked about it, we were all talking 11% partial response rate. Do you think that this drug will have any role to play in this group of patients? The median overall survival with placebo was 4.14 months, and the median overall survival with nivolumab is 5.26 months. And this drug got approval with this data in Asian population. But we always talk about what is 1 month difference. But when you talk about that in third line setting, this is where research progresses actually. Then the researchers went back and chose their patients correctly for using nivolumab. It came to second line and first line, which we will see in subsequent slides. Similarly, the pembrolizumab data in the third line, fourth line setting, response, this is just a single arm data, 11% response rate. Then to qualify that response, PDL1 score, the pembrolizumab used the CPS score. I will come to the CPS versus the TPS score in my subsequent slide, but pembrolizumab has always looked at CPS score in gastroesophageal cancers. And there the CPS score more than or equal to 1, there was some better outcomes. So that this data led to the approval by FDA for only PDL1 positive tumors, and CPS score was the score which was approved for the same. There was no major, I will not talk about much of safety signals here, because throughout this, there is no major safety signal other than the usual ones which immunotherapy is associated with. Then there was another trial in the same setting, third line, avelumab. Unfortunately, large trial got a bad result, and this drug has never been attempted, or we don't have any further data in second line or first line with avelumab. So that brings us to the second line studies. So with the third line approvals, the second line studies were designed. The keynote study, the keynote 61, one of the key studies which we were looking at, because it's second line setting, this is a setting where the paclitaxel plus ramucirumab in gastric, gastroesophageal, and adenocarcinomas was approved. This was a negative trial. The curves crossed each other. The PDL1 positive patients actually did worse in the pembrolizumab arm. Then again, to see whether there was any group of patients actually who benefited, the CPS score more than or equal to 10 was taken. there appeared to have some benefit in this group of patients, which is important in the way the next trial is going to be designed and the next results come out. Also, the MSI high tumors appear to have a benefit. MSI high is something which we always search in all our cancer patients these days, but it is something which we don't get. And in this study, there were only less than 5% of the population who were MSI high, but they appear to have a benefit as compared to the paclitaxel. The major critique of this study is that the control arm had paclitaxel alone and not the paclitaxel plus ramucirumab. So let us not talk about that study now. The next one, which led to the approval of pembrolizumab in second line setting, is the Keynote 181 study. So as we see the approval or the design, this trial specifically looked at two things actually. The second line setting, either pembrolizumab or chemotherapy, it was locally advanced squamous cell carcinoma or adenocarcinoma or esophageal and GE junction. All comers were separately assessed. Patients with esophageal cancer separately assessed and CPS more than or equal to separately assessed. That is the stratification. Results showed that if you have a squamous cell carcinoma patient and those who had a more than or equal to 10 CPS score had the greatest benefit. This is the data from this trial. So if you see the overall intent to treat population, the median survival is similar with the pembro and chemotherapy. So it was not positive for the overall population. But there was a stratification to see whether the outcome would have been better in the patients who had a CPS score of more than or equal to 10. And there is a significant difference where it was 9.3 versus 6.7 months. And if you take a 2-year survival, approximately almost 25% of the patients with a CPS score of more than 10 were surviving in second line, which is significant as compared to 10% in the other arm. If you take the squamous cell carcinoma alone patients, there is some improvement, but it is not that statistically significant. So this led to the approval of second line pembrolizumab as compared to chemotherapy. The chemotherapy was paclitaxel or irinotecan in this group in CPS score more than or equal to 10. So that is where the pembrolizumab moved from third line to second line. Similarly, the nivolumab study, this is called Attraction 3 study. Again, a phase 3 randomized trial of single agent nivolumab versus investigator's choice of chemotherapy. All these patients were the ones who had progressed or are intolerant to first line fluoropyrimidine and platinum based therapy. And the primary endpoint was overall survival, and the pembrolizumab actually looked at a TPS score and of PDL1. So patients were treated until progressive disease or unacceptable toxicity and were allowed to continue beyond first progressive disease as per the investigator's judgment. So the conclusions of this study, the median overall survival was 10.9 versus 8.4. The second line treatment of nivolumab, it met the primary endpoint. There was significant improvement in overall survival versus either paclitaxel or docetaxel in unresectable squamous cell carcinoma patients. So most of the subgroups trended towards an overall survival benefit with nivolumab here, including those with variable PDL1 levels. It was a tolerable safety profile, and there was no detriment in the health-related quality of life. So nivolumab may be a second-line standard of care in advanced esophageal squamous cell carcinoma. So we saw the second-line approvals. We got the approvals are for pembrolizumab in CPS score more than or equal to 10 and nivolumab in all esophageal squamous cell carcinoma patients, regardless of the PDL1 score. That is where we stand in terms of second-line ICI approvals. Now we go to the latest ones, that is the first-line ICI approvals. This approach is either about a immuno-oncology, immunotherapy alone, or immuno-chemo combination, or chemo alone. So the Keynote study, the pembrolizumab study, again locally advanced unresectable metastatic adenocarcinoma of esophagus or squamous cell carcinoma, who have the patients were stratified Asia versus non-Asia, because some of the studies previously were exclusively in Asian patients. The chemotherapy was 5FU and cisplatin in once in 3 weeks protocol, and patients were either given pembrolizumab or placebo. the dual primary endpoint of overall survival and PFS. Secondary endpoint was response rate. So this study again stratified the group of patients to all these esophageal squamous cell carcinoma patients or the ones who had a CPS score of more than or equal to 10. And this is derived from the previous keynote study, which established pembrolizumab in second line setting in CPS score more than or equal to 10. So if you take this particular group, this is a really impressive data with good hazard ratio of 0.57. If you give chemotherapy plus pembrolizumab versus chemotherapy, the 2-year survival is 30% in patients who get pembrolizumab and chemotherapy, which is significant in esophageal cancer, almost 1/3 of the patients surviving for 2 years versus 15% of them surviving for 2 years in chemotherapy alone now. If you take the entire population of squamous cell carcinoma patients, again a 30% patients surviving for 2 years and 17% in the chemotherapy arm, hazard ratio of 0.72 with significant p-value. So this study, if you take all comers, it is still significant, but the quantum of benefit is not as much as the patients who have PDL1 more than or equal to 10% CPS score or squamous cell carcinoma. And this is the PFS data, which is again showing more benefit in the patients who are having a CPS score of more than or equal to 10. It was a reasonably safe treatment. Most of the treatment-related toxicities, as expected in most of the immunotherapy, chemotherapy combinations. So treatment-related adverse events were almost similar in pembro plus chemo arm, grade more than or equal to 3 toxicities, 72% versus 67%. Discontinuation 19.5 versus 11.6%, and death 2.4 versus 1.4%. Similarly, the other study, the nivolumab study, I don't know why this study was not named as an attraction study, because if you see the chronology, it was from attraction 4 to 3 to this. This is a checkmate 648 study. Another bold attempt by the nivolumab arm, where they have actually looked at a no chemotherapy arm here. So the control arm is chemotherapy alone, similar to the pembrolizumab study. The research arms are either nivolumab plus chemotherapy of the same protocol or nivolumab plus ipilimumab in this group of patients. Unresected, advanced, recurrent or metastatic squamous cell carcinoma of esophagus with no prior systemic therapy, good performance score, co-primary endpoints of OS and PFS in patients with tumor cell PDL1 more than or equal to 1%, and this is the TPS score based. Baseline characteristics similarly matched. If you see the PDL1 expression of TPS more than or equal to 1 is seen in almost 50% of the patients, who all will now qualify for immunotherapy in first line based on the result of the study. So if you take the overall survival in the group of patients who have a PDL1 of more than or equal to 1%, Nivo plus chemo, 15.4 months versus 9 months in chemotherapy arm. Significant improvement, hazard ratio 0.54. If you take the no chemotherapy arm, that is Nivo plus IPI versus chemotherapy, again 13.7 versus 9.1 with hazard ratio of 0.64. So this is a positive trial, which also establishes an immunotherapy plus chemotherapy combination as first line therapy in esophageal squamous cell carcinoma, and here specifically the TPS score of more than or equal to 1%. And if you take all randomized patients also, there is an improvement over chemotherapy. So the trial meets the primary endpoint as the previous one with pembro plus chemo. PFS benefit in the PDL1 score more than or equal to 1, definitely there's a PFS benefit which is significant, but that is not seen in all randomized patients. So the conclusions in patients in first line squamous cell carcinoma, Nivo plus either chemotherapy or ipilimumab significantly improves overall survival versus chemotherapy alone. And specifically in the PDL1 expression more than or equal to 1%, and in the overall study population, the overall survival benefit is seen. Safety is consistent. So this is again potential new first line treatment standard in advanced squamous cell. So we have 2 trials which have established immuno-chemo combination or immuno-immuno combination in first line therapy. Now, what biomarker are we going to select? CPS, TPS, MSI, tumor mutational burden. I think that we will discuss in the panel discussion. So we know that the combined positivity score is the percentage of PD-L1 staining cells divided by the percentage of tumor cells actually into 100. And my take is that if you keep CPS, we will have a better negative predictive value, because if CPS is high, we may, if a CPS is low, that patient may not actually have a high expression of PD-L1 regardless of what test we are going to do. And the TPS score is actually the one on the tumor cells only. The other, the FDA approved biomarkers, the tumor mutational burden, the MSI high, as we discussed before, these are also, when you use an tumor agnostic treatment approvals, we can use immunotherapy in esophageal malignancies based on this data as well. So the summary from PD-L1, it is an IHC marker assayed by multiple antibodies, each antibody imposing a burden on the tissue and the workflow and validation burden in the lab. Good communication with the lab is important. So I think that's my conclusion slide. So we saw how immunotherapy has moved from third line to second line or other subsequent lines to the first line in esophageal cancer. And this approval has come from these two major trials which have published recently. IO-IO combination is also an option in patients who are ineligible to chemotherapy. And PD-L1 testing now, I think, is recommended in all patients. Whichever PD-L1 test we do, if you have a high score in PD-L1, the chance and the response rates and outcomes are better. So that's all I have. Thanks a lot for the patient listening.
Thank you, Prasad. As usual, a great job by you. I think the way you moved the molecules with the trials gradually from later lines to first line, and then also made us realize the importance of the biomarkers. And the last three take-home messages, a lot to learn from you about how to present the data and how I can use the data to incorporate in clinical practice on Monday morning. More than that, you stick to your time. True to, I have always bet upon you, and you have stood true to my expectations, or rather beyond that. Thanks a ton. I'll again invite you very soon for one of my other conference also. Be prepared.
Thanks a lot.
Thank you, Prasad. Excellent job. Yeah. So without further ado, I think we will now go on to invite Dr. Sana Al-Sukun. She is the adjunct professor of medical oncology at the Al Hayat Oncology Practice in Amman, Jordan. More than that, chair of International Affairs Committee of ASCO at the Hayat Oncology Practice in Amman, Jordan. And we started the esophageal cancer. We now move on down to gastric cancer. Ma'am, thank you so much for being a part of our conference. Your presence is hugely enlightening, and I'm sure you will do complete justice and make us give us some practice-changing outcomes on gastric cancer and how I am going to treat gastric cancer in 2022. Thank you so much, ma'am, for honoring us with your presence.
Good evening, and thank you for the kind invitation. Really glad to join you. And I hope everybody is well with this corona pandemic, and hopefully, inshallah, to join you in person in future meetings. And actually, I was challenged by my colleague for sticking on time. So without further ado, I will start my talk, and this is the outline. I will be starting with basics, are still basics for practice in 2022. Quickly to remind you, what are the basics I'm talking about? We still remember the days when surgery and radiation therapy gave us a survival of only 3 to 4 months to our patients. It took around 20 years for the use of 5-fluorouracil and combination chemotherapy with oxaliplatinum in particular, or platinums in general, in addition to plus minus epirubicin or taxane, and we managed to have a median overall survival of about 1 year. Lately, indeed, we managed to extend our armamentarium with a new drug. It took like 20 years from the 90s to 2015 to introduce a new molecule to the market, Lonsurf, in the third line setting, improving overall survival to about 1.5 years. So what we have learned, chemotherapy prolongs survival and improves symptom control. 5-fluorouracil-based combinations are better than single-agent 5-fluorouracil. As you saw, 6 months median survival as opposed to 1 year with combination. And indeed, your golden agent to combine with is cisplatin or platinum-based treatment. Docetaxel triplet mostly improves overall response rate, minimal impact on overall survival, huge increase in toxicity. The following drugs are interchangeable. As you can see, platinums. And indeed, oxaliplatinum is as effective as cisplatin, indicated by the German trials, and even better toxicity profile. We are all familiar with using Folfox these days. Capecitabine is as effective as 5-fluorouracil, as indeed reflected in the REAL-2 trial. 2 trials proved that. S1 is as effective as fluorouracil in the hands of our Southeastern Asians, Japan, China. And irinotecan is as effective as cisplatinum. That's in the second line setting. Median survival for gastric cancer by virtue of these combinations in the front and second line goes up to a median of 1 to 1.5 years. Quickly to remember, second line chemotherapy, single agent, taxane or irinotecan improve overall survival, and the combination of both doesn't really add much above taxane by itself. Please keep that in mind. It increases overall response rate without increasing overall survival. And paclitaxel is as effective as irinotecan in the second line setting, and definitely as effective as the more expensive nab-paclitaxel, widely marketed as an alternative to paclitaxel. And we all like paclitaxel because it's cheaper with available generics. Lonsurf was introduced in 2015 in the third line setting. We didn't have much to offer our patients in the third line setting. And it helped to extend the overall survival by 3 months, by 2 months and 2.5 months, especially among the patients who underwent gastrectomy. Still helpful for those without gastrectomy, especially that hematologic adverse effects are higher for those who underwent gastrectomy. So we learned those basics, and in 2022, I still remember those basics when I practice. Also, I learned that not all gastric cancers are created alike when it comes to molecular biology or oncology. Look at the WHO classification. This is the 5th edition, and it's looking at histologic subtypes, identifying 4 different histologic subtypes, indicating differences and heterogeneity between patients when it comes to histologic subtypes. These differences in histology that we realized a long time ago among our patients is definitely driven by different molecular subtypes for gastric cancer, illustrated in clinic and in the lab, not in the clinic, for our patients. Yes, unfortunately, we cannot do molecular subtyping for our patients. I don't feel bad until now very much, simply because, yes, we know all the subtypes, but so far the benefit reflected in clinic is about 10 to 20%, as you will see with EBV subtype and microsatellite instability subtype, both being more responsive to immune checkpoint inhibitors. So, but otherwise, that doesn't change our management. What really is practical change for our management, for our patients, particularly in the second line setting, has been the introduction of next generation sequencing and molecular profiling. This is not molecular subtyping, it's molecular profiling, looking at alterations in genomics of the tumor in patients. And indeed, 40%, that's a huge number. 40%, more or less similar to what you see in lung cancer patients almost. 40% of tumors harbor amplifications. They're not mutations, they're amplifications. And as you can see, quite commonly identified genes in other tumors with targeted therapy identified for most of those. As you can see, FGFR receptor 2, KRAS, HER2, EGFR, and MET. And all of you have heard of the recent introduction of targeted agents for most of these, particularly for MET, for KRAS G12C, as we will see in a minute. And the good news, those mutations are mutually exclusive, meaning that if a tumor has one, unlikely to have the other. So we've learned that. We learned also that targeted therapy in targeted population improves outcome, but in non-targeted population, it adds nothing but toxicity and financial toxicity as well. That's why when we added the EGFR inhibitors and the vascular endothelial growth factor inhibitors, the MET inhibitors, to all comers of patients with colon cancer, we have not seen improvement in overall survival. Not a single trial of those listed here, adding the EGFR inhibitors, cetuximab and panitumumab, or even bevacizumab, or ramucirumab, or as you can see, other targeted agents, frontline therapy, not a single agent improved overall survival. But when ramucirumab was added to the second-line chemotherapy to all comers of patients with colorectal cancer, in the REGARD study, there was a definite trend for improvement of 2 months in overall survival. And when it was taken to the phase 3 trial, the improvement was held with a consistent improvement in overall survival of 2 months. How could you explain that? The reason probably is that we do have not only heterogeneity between patients, but we do have heterogeneity over the time span in the same patient and between different metastatic foci. Indeed, in this study, nicely illustrated that 30% of patients will have discordance between the pathology of the primary and the metastasis in terms of molecular profiling, making liquid biopsy more likely to reflect the status of the genomic findings in patients with gastric cancer. So, just a minute. That takes us to the targeted agents that have proven to be successful in the clinic. Herceptin, of course, in the TOGA phase 3 trial was the only agent when added to chemotherapy in the frontline setting to improve overall survival, as you can see. And the definition was patients with IHC +3 and +2 with amplified genomics for HER2. However, in the frontline setting, when pertuzumab was added, there wasn't that improvement in overall survival, except, as you can see here, the final analysis confirmed reduction in the risk of death of 15% in the final analysis when the trial was updated, consistent with the concept or proof of concept of targeting the proper mutation. In the second line setting, however, we didn't see what we saw in breast cancer. T-DM1 did not improve survival. And that indeed would be expected if I remind you of what I just shared with you, that 30% discordance rate. So heterogeneous HER2 expression could explain the lack of benefit. And indeed, when that trial was analyzed for homogeneity of expression of of HER2, when it was more than 80%, there was improvement in overall survival. So we need to account for heterogeneity of expression when you are using targeted therapy, something that is challenging us in the field of gastric cancer. That's why when deruxtecan just lately was introduced into the armamentarium of targeting HER2, it indeed provided a great alternative. It is a monoclonal antibody with an excellent payload. It's an exatecan derivative, quite toxic to the cells, but the good news, the number of molecules carried by each monoclonal antibody is higher than what you see with T-DM1, and the linker is specific to be cleaved in the tumor cell. Not only that, it can leak from the tumor cell to the surrounding tumor cells. So if a tumor cell is positive for HER2 and its neighbor is not, that neighbor that is not positive for HER2 will be attacked, at least in theory. And guess what? In the DESTINY-01 trial, there was, when deruxtecan was examined in the second line setting among patients who has been treated with trastuzumab and progressed, there was a remarkable improvement in response rate of 50%. as compared to what? 14% when you choose any other regimen chosen by the physician treating the patients. And the overall survival was also remarkable, improvement of about 4 months in overall survival. That's a lot for gastric cancer. And the good news lately, it was updated with cohort 1 and cohort 2, including patients with IHC staining cohort 2 of 2+, even if the FISH is negative, and IHC 1. And guess what? There was improvement in response rate. Excuse me. There was improvement in response rate, and the duration of response was also enhanced in both. You are talking about a median duration of response of 1 year in patients treated in the second line setting with IHC +1 only. Of course, no pain, no gain. We have to pay attention to myelosuppression and testitial pneumonitis. Keeping on with the success of targeting proper mutations in gastric cancer, we have started to target the FGFR receptor 2. We have seen success in biliary cancer. And right now, the SHINE study examined the efficacy of this agent versus paclitaxel. Unfortunately, we didn't see much success, but similar to what we saw earlier, when there is homogeneity in, that's the trial, just FGFR expression by IHC and gene amplification by CT and DNA, no impact on overall survival or progression-free survival in the intent to treat population, despite a difference of 1 month. But look at the patients who had IHC +2, +3. You can see a significant improvement of 3 months in overall in progression-free survival, and even doubling when you limit the analysis for those that have an IHC in more than 10% of their tumors. You need homogeneity. Those had only those who had 5% had better improvement instead of the intent to treat analysis in general. But look at the benefit here, doubling in the progression-free survival for IHC more than 10%, which is, by the way, reminding me, this is the definition we use for breast staining for breast cancer. We do not settle for 5%. So more than 10%, excellent for response to the FGFR2 receptor antibody. Claudin 18.2 is another epitope recently discovered to be exposed by the malignant transformation in gastric cancer. And it's a monoclonal antibody that targets similar to mechanism of action of a receptor. It targets a tumor cell. And again, you see the overall patient population, there is a trend for improvement in overall survival, but it's mainly driven by the patients who express Claudin 1.2 in more than 70% of the cells. Homogeneity of expression is the key to derive that benefit. These, indeed, subset analyses are quite important. All these drugs are quite expensive, and you'd like to know that your patient has a very good chance of responding before using them, despite the fact that the overall study in the intent to treat population is positive. I wouldn't be using this drug if I have access to it, except for those that have significant staining. Finally, immunotherapy could potentially improve overall survival. Immunotherapy this year has come strongly, as Dr. Prasad just shared with you, to the world of upper GI tumors. Indeed, it works in esophageal, gastric, even biliary, despite the modest improvement in biliary cancer. So let's look at the data in the gastric cancer population. Efficacy of intent to treat in refractory disease has been examined in the Attraction 2 study. And as you can see here, when nivolumab was compared to placebo, there was significant improvement in overall survival in the beyond third line setting. We don't have options for those patients independent of PD-L1 status. However, that also was also demonstrated for what looks like a benefit for pembrolizumab as well, indicating maybe exposure to chemotherapy in the previous line settings sensitizes the tumor for immunotherapy in the later line setting. Immunotherapy, when compared to chemotherapy as maintenance in the frontline setting, after completing first-line therapy, as you can see, there was no significant improvement in overall survival in the Javelin trial. When it was compared head-to-head in the second-line setting, pembrolizumab was compared to paclitaxel. For patients with PD-L1 positive tumors, there was no improvement in progression-free survival even after the selection. And in the third-line setting, when avelumab was compared to paclitaxel, there was no impact on overall survival, despite the fact they even tried to select PD-L1 status, leaving nivolumab the only drug to improve outcome in a third-line setting based on the ATTRACTION-2 trial. So immunotherapy was not superior to chemotherapy. Yet, the addition of anti-PD-1 to first-line chemotherapy seemed promising, as you can see here in ATTRACTION-4, as we will see in a minute, CheckMate and Keynote 062. Let's look at addition in ATTRACTION-4 Asian population, which actually make everybody skeptical about the reproducibility of the results in other parts of the world. But look at the results over here. Nivo compared Nivo plus Capox, or what we use. They use S1 oxaliplatinum, we use Xelox or Folfox, compared to the same regimen without Nivo. And there was a remarkable improvement in progression-free survival, but not yet improvement in overall survival, quite disappointing. Until 649 indeed was presented comparing the same combination with Folfox or Xelox, more representative of what we use, and I bet in what you use in India, talking to my colleagues, restricting definition to PD-L1 positive use to PD-L1 CPS score of at least 5. And as you can see, remarkable improvement, not only in progression-free survival, but overall survival of about 3 months. And indeed, that benefit is mainly driven by the subset of patients with more than 5% expression of CPS score. Indeed, similar results were lately reported for all patients with a recent update to make sure that what we have seen really holds with further follow-up. And as you can see, for patients with CPS score of at least 5, that was reported last ESMO. And as you can see here, the overall survival benefit is still holding and the curves are still separated with further follow-up of about 4 years, but no impact on for the patients in the intent to treat analysis or randomized patients. So CPS score more than 5, significant improvement in overall survival when nivolumab was added. Lately, just last ASCO, there was a significant improvement in overall survival for nivolumab and ivolumab, as you saw in esophageal cancer, squamous cell carcinoma, which is not what we saw initially for gastric cancer. That's probably because of different molecular subtyping. And in detail discussion has been presented by Dr. Prasad, just indicating that when you are talking about gastric cancer or esophageal cancer, adenocarcinoma versus squamous cell carcinoma, completely different molecular subtyping, and you cannot extend results from one study to another. So first-line therapy for advanced gastric cancer. Interestingly enough, from the TOGA trial in the world of targeted therapy, we didn't have anything up until 2021 when we had nivolumab in the frontline setting. Significant advances I'm talking about. Minor advances of adding in the for low performance status immunotherapy, I do not consider it that much of a difference for our patients. Interestingly, nivolumab was the one to improve overall survival. When you took pembrolizumab to the frontline setting in a non-inferiority design compared to chemotherapy among patients with low PS, there was indeed more or less similar overall and progression-free survival. It was non-inferior. I cannot say it was superior. Even when they restricted their randomization to patients with PD-L1 positive status. And when it was compared head-to-head, more or less similar to Nivo in the CheckMate study, In the keynote study, there was no survival benefit demonstrated from adding pembrolizumab to chemotherapy, which is quite indeed puzzling. So why are the results are different? Speculation is that the PD-L1 assay used in the CheckNote studies is completely different from the keynote studies. You know, S142 used in the keynote studies as opposed to C223 that could have detected selected patients better. When it got the chemo backbone, oxali and versus cisplatin, it was FOLFOX and Delox as opposed to cisplatin 5-FU in the keynote study. Immunotherapy, could it be really because differences in nivolumab and pembrolizumab? Well, hard to sell that, but that could be one. And very important, immune checkpoint inhibitors beyond the first line, diluting the overall survival impact. However, yes, it was more or less similar. I cannot say that an 8% difference in the crossover can explain the loss of benefit in the pembrolizumab trials. Finally, biomarkers. We need to check biomarkers better to select patients for checkpoint inhibitor therapy, and of course, microsatellite instability in 20% of gastric cancer patients is quite important indicator of excellent response to immune checkpoint inhibitors. Indeed, just last couple of weeks in ASCO GI 2022, nivolumab plus ipilimumab yielded a higher rate of complete pass CR in the neoadjuvant setting when used for 6 cycles only among patients with adenocarcinoma, whether gastric or esophagogastric. 60% complete path response, questioning the need for really surgery. That was the first report of such, and indeed minimal toxicity because we're talking about only 6 cycles. In addition, we know that high tumor burden in gastric cancer in particular indicates better response to immune checkpoint inhibitors, pembrolizumab or nivolumab. Another indicator is tumor infiltrating lymphocytes, CPS score, and EBV subtype. That has been examined in different studies. EBV subtype is quite sensitive to immune checkpoint inhibitors. CPS score of at least 10 is indicator of excellent response in the second line setting when pembrolizumab was compared to paclitaxel, a subset of patients that had CPS score of at least 10 really derived benefit. That was, however, a post-hoc analysis. And tumor infiltrating lymphocytes, those can be probably with artificial learning more and more accurately detected, indicate better response. So in 2022, how am I going to treat my patients? You know, unfortunately, it's not much of what I used to do. I would check patient performance status. I would focus on HER2, microsatellite instability, and PD-L1. It's very expensive to send for NGS. And if I send to NGS, I have to know that I have access to the new targeted therapies. If I were practicing in the US, I would do it. When I'm practicing in Jordan, this is what I do. I check PS, HER2 because I have access to the targeted therapy, microsatellite instability, and PD-L1 because I have access to immune checkpoint inhibitors. Despite that, only limited number of patients can afford them. And for the HER2 negative, I start with 5-FU based doublet. My favorite is FOLFOX or Xelox because they're tolerated. If nivolumab CPS score is more than 5, I offer it to the patients depending on their insurance or finances. And for the HER2 positive, I add trastuzumab up front. For those who have low performance status, I could use pembrolizumab. In the second line setting, I'm very much inclined to use paclitaxel plus minus ramucirumab. We go back to microsatellite instability. If it's positive, I am inclined to use a checkpoint inhibitor. Let's be honest, Pembro or Nivo, whichever is cheaper and more available. Performance status is important, as I mentioned. I offer the patients, but I don't do it. I tell them about what's the recent advances, but I do not push to do the NGS indeed. And we talked about different NGS-driven targeted therapies. Antrak has been there forever, and recently Claudine 1 and FGFR receptor inhibitor are really major advances. If we have deroxytecan, which we do not have in Jordan, I would have offered second line treatment with deoxyticam for HER2 positive patients. But unlikely to be present or available soon, so that leaves me with a Lonsurf for the third line treatment, plus minus, again, if they can afford nivolumab. With this, I conclude, and thank you for listening. I hope I were on time. How good did I do?
Ma'am, it was splendid. We thoroughly enjoyed, and especially the way you started telling that basics are basics, and therefore we need to stick to that. And of course, you told about the incorporation of targeted therapy in immuno-oncology molecules. Thank you so much, ma'am. And the last slide gives us a clear flow chart of how we need to take care of gastric cancer patients in our country, because you seem to be doing exactly what we do here. With, as you rightly mentioned, many of our patients suffering from financial toxicity. I think it was excellent, and we thoroughly enjoyed. We do have some questions, madam, in the chat box. And I think you did already answer a few of them during your talk. Having said that, Dr. Shikhar is asking, does IHC need to be repeated after first-line trastuzumab because HER2 loss has been reported?
Definitely, I try actually to repeat every time I can. The reason, as I showed you, there is a 1 in 3 patients will change their, actually, they will change their status. The tumor will change its expression of all mutations. IHC staining changes 1 in 3 patients. So I would definitely, if I have access, gastric cancer is easy. Most of the time we need to check on the tumor with a biopsy. Yes, I do that.
And you already answered one question, Dr. Viraj, very well, that despite the similar trial design of Attraction 4 and Checkmate 649, why one showed OS benefit and the other did not? I think in a very good tabular form, you made us realize that. So yeah. Thanks a ton for everything, ma'am. You were dot on time, but more than that, you gave us excellent take-home practice messages.
Thank you. I'm so glad that you enjoyed it. Again, thank you for the kind invitation. You're doing a great job.
Thank you so much, ma'am. Thank you. With that, now we move on to the third session for today. Dr. Bharat Vaswani, a very esteemed colleague of mine, who is a senior consultant in the Yashoda hospitals in Hyderabad, a very dear colleague and friend of mine, will talk about all the important abstract presentations from ASCO GI 2022. And I'm sure through his presentation, he'll be able to give us practice-changing messages from the ASCO GI abstracts. Bharat, over to you for the coming 20 minutes. And I'm sure we'll all thoroughly enjoy your presentation as always.
Sir, are my slides visible or am I audible, sir?
Very much.
So
both.
Let me thank Dr. Satya, sir, whom I consider as my elder brother, for this kind opportunity to be the part of this organizing committee. And again, thanks for making me present these abstracts. There were 5 important abstracts which were part of oral and rapid abstract. And I'll take 2 to 3 minutes in presenting each abstract. Let me thank Dr. Sana Madam because she has presented 2 of the things that I wanted to present. But I will like to re-emphasize something because that is something that probably in future we'll be following accordingly. So according to me, this was probably the most important abstract which was presented in esophagus and stomach. The thing to answer was, should FLOT chemotherapy be the neoadjuvant chemotherapy of choice for all patients in localized GE junction tumor, including those with MSI high? That was MSI high. Or is there a significance of doing a MSI testing in localized GE junction tumor? Please remember, not in metastatic, but in localized. And that was answered by this prospective phase 2 neo-NIPIGA study, neoadjuvant nivo-ipi gastric adenocarcinoma study, which was from the French group. Now, what all we know is, in the meta-analysis, FLOT chemotherapy in those with a MSI high, in fact, is detrimental. So a 5-year DFS was 70 with FLOT versus 77 without FLOT, and for a 5-year overall survival was 75 with FLOT versus 83 without FLOT. So probably, and we have I have 2 patients like that who had progressed within 4 months. What about giving a MSI in this patient with an immune checkpoint inhibitor? So that was the gist of this presentation. So please remember, being a short study, it was a pathological complete response. What was the primary endpoint? So you gave 3 months, that is 6 doses of Nivo and with 2 doses of Ipi. Then we did a surgery and followed by 9 months of adjuvant treatment. The total patient included was 32. Look at down. Out of 32, 31 patients showed response. 94% response rate. 29 undergone surgery. 2 patients refused surgery because they were in CR. So they did not want to undergo surgery, and at 1 year, they are still free of disease. So that is probably amazing. Now, when you look into the primary endpoint, 58.6% had pathological complete response as per as post-operative setting. So 6 of the 10 post-operatively after 3 months of immunotherapy had no disease at all. Now, when we talk about event-free survival and overall survival, 30 patients did not have any event. So 1 patient progressed and 1 patient died post day 3 of surgery. Other 31, there was no. And out of 32, 31% patients are still surviving. So only 1 patient has died. That also post-op complication. 30 patients have no event. 1 patient only have progress. So this was something which was amazing in this subset of patients. Side effects manageable, only 25% grade 3 toxicity, common is being diarrhea, some sort of hepatitis, and some sort of a decreased appetite, which were clinically significant. So the first take-home message is, yes, this should be a practice changing because 59% pathological CR has never been achieved in any of the. Check your cross 48, check your flot 20 to 30. So for the first time, we are having a study in this which has a 60% pathological CR. Only 25% grade 3 or 4 toxicity. More importantly, 94% of the patients included are free of events at 12 months follow-up. So for me, the first take-home message is the advantages. First study in prospective setting which shows the role of immune checkpoint inhibitor in neoadjuvant setting. You never might have a phase 3 because the incidence is 2 to 5. A very good, probably the best pathological CR till now, which is far better than a chemotherapy. Again, reiterates the importance of doing a MRSI testing, even in the localized junction. Probably it will tell you not only that who's at risk in family, but the best drug to choose. Again, a small phase 2 study, but you can't get a phase 3 because of the rarer, and probably if possible, phase 3 study will validate these findings. The second study, also told by Dr. Sana, this was the final update of gastric O1 Destiny, which was a study which compared trastuzumab deruxtecan in 3rd line or beyond versus a chemo care. So please remember, more than 2 lines of chemo had already been taken. So it was a 3rd line or beyond, comparing trastuzumab deruxtecan versus a treatment of choice. Just look into the amazing disease control rate. In the 3rd line and beyond, 85% disease control rate, 51.3% versus 14.3% against the standard of care. And more importantly, 12.1 months duration of response. This could hardly be achieved in the 1st line, and you are seeing a drug in the 2nd line, which is giving you such a response. Now, when we talk about the most important point, 40% reduction in the risk of death with a quantum of benefit of around 4 months. Side effect manageable, hematological toxicity, and only 2 patients had grade 3 interstitial lung disease and 1 patient had grade 4 disease. So probably grade 3 and 4 were manageable. So the second take home is 40% reduction of death against the standard of care in this population, around 3 times better overall response rate, side effects manageable, which were hematological, and only 16 patients overall had an interstitial lung disease. Both were grade 1 and 2, only 3 patients had grade 3 and grade 4. So for me, the take home message from this is that trastuzumab deruxtecan is a standard of care in the 2nd line, provided your HER2/neu is still amplified in the 2nd line, the question asked, and Destiny trial will definitely change destiny of many of the gastric cancer patients. Now, the third important thing which has already been discussed, but I want to point something. Please remember for PG, these are the 3-4 trials you have to remember in the 1st line. For squamous, Keynote 590 and Checkmate 648. For adenocarcinoma, again a Keynote 590 because 25% were adeno. Checkmate 649 were only adenocarcinoma. So these were the 2 updates which has been presented in this ESCO 2022, and I would like to tell in short what are these updates. So the first trial, please remember, Pembro plus chemo versus it was a chemo, but these were adeno plus squamous. 11% were GE junction and 89% were esophagus. So you can take it in both ways. So esophagus plus GE junction, chemo plus pembro versus only chemo. Please remember 22 months update and 33 months update. The main endpoint was to check in squamous cell in more than 10, then overall in more than 10, then esophageal squamous, then adenocarcinoma. And when you look into the quantum of benefit, the best response, close to 14 months survival with the best hazard ratio was in CPS more than 10, especially squamous, followed by overall 0.64, and then in adenosquamous, when you compare both, it was 0.73. So please remember the main quantum of benefit is with CPS more than 10. Now, when you look into the subset parameters, there was benefit in everywhere, but the main benefit or the benefit which was there was mostly in CPS more than 10, which was 0.64. So I doubt whether you should use in CPS less than 10, that I will be telling. Why I should use it? Because of these two things. Double or 16% improvement in response rate, but that is not important. At 2 years, 4 times more patients are still responding when you give the combination of pembro with chemo. Probably the strongest reasons to say that I should use the immuno. At 2 years, 4 times more patients are still responding. Of course, quality of life similar. So these were the two updates. Let me talk about Checkmate 649 because that is why I will write it. Please remember, these were all adenocarcinoma, GE junction or gastric, nivo plus minus chemotherapy. So it was in CPS more than 5, and that is the main gist of my presentation. Again, when you look into the update analysis at 13 months and at 24 months, the main thing was CPS more than 5, OS and PFS. And other was then in month and then in overall. So the main quantum of benefit again is those with a CPS of more than 5, 0.69. And when you look into the other subset, the benefit was there. But again, I like to tell you that the main quantum of benefit was defined by those with a CPS of more than 5%. Two things I would like you to remember was 2 subsets which did not do well as far as subset. Every subset did well except for those with a peritoneal met. So that could be debated that if you have a peritoneal met, maybe should you use your immuno or not. And secondly, in those with a lower of albumin. So probably a malnourished patient, the quantum of benefit with immuno was not there. The toxicity, 15% toxicity grade 3 when because of chemo. But when you talk about immune-related toxicity, it was less than 5% grade 3 to 4. So probably a safer drug, and I think we don't have to worry. Now let us take both together. These 2 trials were. So according to both, the main purpose in Keynote 590, the primary endpoint was met in all, but CPS more than 10 does better. When in Checkmate 649, which was adeno, CPS more than 5, which was a nivo, did better. Now, when you look into the FDA and EMA approval, FDA has given approval for nivolumab in all patients, less than 5, more than 5, and FDA has still given pembro also for less than 10, more than 10. But EMA has been very specific. EMA has given only based on the primary endpoint. So there comes the golden question. What is the right way according to us? So for me, I think so the best way is to give in those who have according to the primary endpoint. As you look into the survival data, those with the CPS of 1 to 4 in Checkmate 649, no advantage, absolute 0. And whereas when you see, they have not checked in 1 to 9. So for me, there is a lack of benefit up to 4, because if you see those subset with 1 to 4, there was no advantage of giving an immune checkpoint along with chemotherapy. So according to me, these were the conclusion that was in the Nile make. Definitely immunotherapy is there to stay in the first line. But I will like to be a bit cautious about in which patient will you use and which patient you will not use. Again, some situation like PS2, malnutrition, peritoneal involvement, you have to debate whether you should give your immuno or not. So my third and fourth take-home message is immune checkpoint to be combined with chemo in first line based on impressive response, double, and long-term response, which was 3 times more. Long-term follow-up, impressive, no new safety signal. And considering the cost and treatment at present, I think we should base our treatment on PDL by CPS score, at least in the first line, being a costly drug and the quantum of benefit. I think I have made my point clear. The last abstract. Can I avoid radiotherapy in an esophageal squamous cell carcinoma? Please remember, most of us, based on Dutch cross study, we give CT-RT in esophagus and neoadjuvant chemo based on plot in adenocarcinoma in GE junction. What if I want to avoid a radiotherapy? and give a 3-drug regimen. So a phase 3 data from the Japanese group, which compared 3-drug versus 2-drug versus CT-RT followed by surgery. So this was a trial schema. Newly diagnosed either neoadjuvant DCF 3-cycle followed by surgery, or neoadjuvant cisplatin 5FU followed by surgery, or CT-RT followed by surgery. Now, I don't want to go into detail because I have to present some more things. Now, let's go into the data of neoadjuvant DCF, because that was supposed to be better than other 2 parameters. And I have tried to compare with Dutch cross study. In fact, definitely you can use it. OS at 3 years is 72.1 versus 51.2. Again, I like you to be cautious because these are cross trials. It is as good as what is in Dutch cross, but I will like you to be careful about the neutropenia aspect. So for me, yes, in a young fit patient, if the patient is not willing for RT, I may think of giving an intensive DCF. Probably the quantum of benefit is the same. So what they suggested is DCF was superior to CF in terms in locoregional squamous cell, but yes, it has significant toxicity which may limit its use. So my last take home is, for a fit patient not willing for RT, as far as this data, neoadjuvant chemo using combination of dosis injectable 5FU is equally effective option. But again, it is a single country Japanese study and we need a 5 or 10 years follow-up. So in a gist, what I have to say, the newer, what was the update in this ESCO in esophagus and stomach? Immune checkpoint inhibitor are probably a better option than chemotherapy as neoadjuvant in localized GE junction tumor with MSI high. Trastuzumab deruxtecan and best second-line option in HER2 amplified metastatic gastric cancer. Long-term follow-up of immune checkpoint inhibitor with chemotherapy. It has the maintained advantage over chemotherapy with no new safety signal. And last but not the least is 3-drug regimen using dosi platin 5FU is an acceptable option as neoadjuvant chemo in esophageal squamous cell, not adeno discussing, in fit patient able to tolerate chemotherapy. So these were the 5 new abstracts that was presented. I wanted to share with you. Sir, if given a chance, I have to present some Lenvima things.
Okay, how much time more?
I'll take 7 or 8 minutes because that is practice changing, sir.
I can understand, but we are almost like nearing the next. In fact, there are some answer on the chat box which you can say, with Shikha telling us that prevalence of MSI is only 5% hardly. 5%. Yeah, and then when Vamshi Krishna checked in 30 patients, he found none positive. So your take on your experience?
I have 2 patients who are positive. Both progressed within 4 months of completion of flawed surgery. Luckily, I could give nivolumab to one of the patients. 16 months down the line, the patient is in complete response. So for me, yes, I have 2 patients who are MSI high in GE junction, both relapsed within 6 months of completion of therapy. One was affordable, MSI high, 14 months now, he is in complete response.
Absolutely. If without presenting, can you just give us in a couple of sentences your take on lenvatinib so that we can then start the next? Say you can just extempore tell us about what you want to convey about lenvatinib.
Now first line treatment in hepatic cancer in advanced setting is either a combination of IO with anti-VEGF, that is what we say, IM150, and second is lenvatinib or sorafenib, whatever you say. As far as reflex, lenvatinib is slightly better in terms of time to treatment progression, overall response rate, and progression without an overall survival. Now, this was the first study in a phase 3 setting, which was called as a launch study. So that suggested that in an advanced cancer patient, I am giving lenvatinib. What if I add TACE along with it? For those patients, there were guidelines for a tumor less than 10 centimeter or multiple tumor less than 10 centimeter, which could be amenable to TACE, and volume of the liver occupied should be less than 50. So one arm contained lenvatinib with TACE, other arm contained only lenvatinib.
And now, the advantage?
That is the most important. The progression-free survival, 52% was extrahepatic, 50% had alpha-fetoprotein of more than 400, 80% of patients were high risk having multiple liver tumor with extrahepatic. The progression-free survival in a phase 3 setting was 10.2 months versus 6 months. So 4 months improvement. 10.2 has not been even with IO anti-VEGF, which is 9 months. So by adding your local treatment in advanced HCC, you are improving your PFS from 6 to 10 months. The icing on the cake is overall survival was more than 17 months from 10 months in a single arm lenvatinib. By adding a local treatment that is TACE, the survival improved by 7 months. Highly statistically significant. So for me, on a Monday morning, if I see a patient with a HCC who has Child-Pugh A, not decompensated, organ function maintained, and if I have liver lesion with extrahepatic, but the liver lesions are amenable to local therapy, I'll start my patient on lenvatinib, which I am doing, but definitely I'll add on my TACE to it, because now I have a data that even with a TKI with a local treatment in a fit patient, I can still reach 17 months. And please remember, these were phase 3 data in a setting, launch setting, 160 in control arm and 160 in the 167 to be precise.
Yeah, okay.
For me, this is probably the most important aspect in terms of my practice change now.
Absolutely. Thank you so much, Bharat. As usual, very enlightening and a fabulous talk, and you were able to cover what all we wanted you to cover. We now move on to a session sponsored by Ally Lilly, and I would request Dr. Vamshi Krishna to take over the proceedings for this session. Vamshi, are you there?
Yeah, good evening, everyone, and thank you so much.
Yeah, a very dear colleague of mine. Vamshi Krishna is the director and head of medical oncology and hemato-oncology in the AIG Hospital in Hyderabad. More than that, an excellent moderator and a very good speaker. I'm sure his presence will add a lot of value to today's meeting. Vamshi, over to you completely now.
Thank you so much, sir. Thanks for those kind words. So in the next 25 minutes or so, we are going to talk about an interesting molecule, really. So I actually have good fond memories of this molecule because it's one of the few things which has actually come into the market after I have started my practice. Of course, immunotherapy is one more like that. But I have been associated with Cyramza right from its inception, at least in India. Now, when you look at this journey in India, the initial approval for Cyramza came in 2017 with second line advanced gastric cancer and GE junction adenocarcinomas. Later on, we did get approval in other settings as well. In 2019, Cyramza was approved for second line metastatic colorectal cancer. In 2020, it was approved in a second line advanced and unresectable HCC. And last year, it was also approved in first line EGFR mutant metastatic non-small cell lung cancer. It is also approved in non-small cell lung cancer. Now, the biggest problem with Cyramza is, I would say it's not an immunotherapy, which is why we don't keep talking about it. But it is a molecule which is like a steady workhorse that is slowly going on in the background. And at least personally, among the indications, gastric and HCC remain indications where I am definitely utilizing it. And metastatic EGFR mutant NSCLC is one more where it is going to make a mark. Next slide, please. Now, when you look at the way Cyramza works, the ramucirumab, it is actually a binding to the VEGF receptor itself. Now, when it binds to the receptor, it can block multiple ligands from binding. Which are these ligands? You have the VEGF-A, the VEGF-C, and the VEGF-D, all of which actually induce angiogenesis in preclinical studies. So Cyramza blocks the ligand, the VEGF-R2, and that helps in preventing the binding of these ligands to the receptor. So that's how ramucirumab works. Slightly different from how, of course, bevacizumab works, the one to which it is, I think, unfairly often compared. That comparison is probably why we tend to ignore ramucirumab in a few other settings. Next slide. So let's see what is the real world evidence of Cyramza, specifically looking in gastric cancers. Now, when we talk of real world data, we have to understand that real world data is not the same as a clinical trial. There are strengths and there are some limitations of a real world evidence. When you are looking at real world data, remember your patients are totally kind of separated from what you see in a randomized clinical trial. You would include patients with comorbidities. When you look at the real world data, you would find patients who are underrepresented in a normal RCT. The performance status could be a bit variable. And again, in clinical practice, all of us are aware, sometimes we play a little fast and loose with the exact definitions. Certain patients who are of an advanced age or who have slightly deranged functions, those who are pre-treated, burden of disease is more than what you would like it to be. All these kind of patients are included in your real world data. There is a validation of the safety, tolerability, and normal efficacy, plus a real world data would account for the ethnic variations seen in a normal country. Having said all that, since it is usually retrospective, sometimes you do have prospective real world, but typically retrospective. So that's one of the disadvantages. The follow-up is not as stringent as we would do in an RCT. That's specifically important for the side effect profile. Often you might miss rarer toxicities which are potentially drug related. So, putting this fact into context, when you look at the real world data, you still get to learn a lot of things. Next slide. So for Cyramza, the real world data from Asia has come in one or two papers. One of the larger one is from the Korean Cancer Study Group. Now, this paper looked at the usage of ramucirumab in advanced gastric cancer patients, either as a monotherapy or in combination with paclitaxel, essentially whatever is the indication for ramucirumab. Next slide. Now, when they looked at the study, almost 86% of patients got the combination and around 14% patients got only a monotherapy. Now, for me, the most interesting point was the duration. In 6 months' time, they actually got 265 patients. So I am sure that for the company, probably Korea is their favorite country after many others. So 265 patients in around 6 months, mostly of them who had gotten it through the expanded access program. The median follow-up was over a duration from around 9 to 9.5 months. Now, interestingly, when they looked at why patients got a monotherapy versus combination, most of the combination patients were significantly younger and also more HR HER2 positive. Now, again, this was, remember, 2015. Today, if we have HER2 positive, probably the pathway is going to be completely a different one. In fact, in India, we have places which are doing the Destiny trial. So, probably that's where we are going to go into. Next slide. So then when they looked at this combination or when they looked at the monotherapy in both the groups of patients, when they looked at the overall survival, remember the second line and beyond. So in second line, they found an overall survival of around 8.6 months in the Ramu paclitaxel arm versus 6.4 in the ramucirumab arm. PFS has been traditionally poor, but it correlated kind of to the trial results. So you had 3.8 months of PFS in the Ramu paclitaxel arm. Again, for me, a more important one is the 6 months PFS rate, which was around 67% in the Ramu pacli arm. All these are kind of what we already know and what we already see in the clinical trial. So the real world evidence seems to support that as well. Next slide. Now, the responses, when you start looking at, in the combination arm, we had a partial response of 16%, stable disease of 49%, and a complete response of 0.4%. Now, this is something that is kind of expected. For me, the important part was the overall response of 38, disease control rate, which is slightly higher percentage of 66%. Progressive disease of 27% is kind of expected. Remember, we are talking about a bad disease like the gastric cancer, where anyway they don't really respond very well. Next slide. So looking at the adverse event profile, By and large, we know that it is quite a well-tolerated drug, and that really was borne out when you looked at the adverse event profile. There was neutropenia, which was higher when you use paclitaxel. There was some febrile neutropenia there. Others, more or less, the grade 3, grade 4 were not significant. The one thing that we are worried about is GI perforation. Again, grade 3, grade 4 are together around 2%, which is kind of what is okay, acceptable range. Next slide. What about Europe? So you also had a paper which looked at ramucirumab as second-line therapy in the metastatic gastric cancer. Again, real world, this was known as the RAMOSS or the RAMOS study. Now, this was a multi-institutional observational study, 25 patients. Again, those who received ramucirumab during the compassionate access program, 11 months follow-up, primary endpoint of safety. 150 patients received the combination, 17 received ramu monotherapy, similar to what was seen in the Korean paper. Next slide. So in this, again, when they looked at the demographics, mostly gastric, few GE junction, and few of the distal esophagus. HER2 positive, again, 29% HER2 positive, 27% HER2 positive. Kind of tells you that ramucirumab does work somewhere in that HER2 positive subgroup. In our country, where we do not have access to everything, this is something which we can keep an eye on. Next slide. So looking at the results from here, again, when they looked at the PFS, you in the combination arm versus the monotherapy, it was 4.3, 4.5 versus 2.7. This is actually better than what was seen in the Korean study. When they looked at the median overall survival, it was 8.3 months versus 4.8 months with the monotherapy. So again, numbers are not too big, but for me, again, consistently, you're seeing that result of around 8 months to 9 months overall survival, which in the second line in gastric is frankly not that bad at all. Overall response rate, 30%, and progression rate, again, was not very high. It was there. Disease control rate of around 60%. Next slide. So when they did a multivariate analysis, they did find that PS less than 1 or more than 1 that impacted whether the patient responded. They also looked at whether the peritoneal metastasis impacted, and that it did. So these were obtained in a non-favorably selected group with poorly differentiated tumors constituting 58%, a peritoneal involvement in 43%. So with a time to progression similar to in the first line therapy. So next slide. Again, looking at the safety analysis, not too much to kind of really worry about. Grade 3 and grade 4 were 5.4 in patients, bleeding in 1.8, very low of hypertension, no treatment related deaths. That is something which is again heartening and again serves to emphasize that real world data can often serve as a good confirmatory endpoint of your clinical trials. Next slide. So combining all the various results and everything else, the median OS around 8 to 9, pretty remarkably similar. Overall response rates, again the same, around 20 to 25%, pretty consistently seen across various studies. Next slide. So from these, we have learned that probably Cyramza is the first biological agent, of course, with all the immunos coming in, though Dr. Bharat did speak very highly of all the immunos and portrayed a very positive light. When we dig deeper into the trials, there are issues there, especially when you talk of the CPS and how they have compared. So in those patients not eligible or with a 0 or a lower CPS, certainly Cyramza remains the biological agent which should still be used in the second line therapy. Real world, we have also learned that treatment patterns are consistent with most of the randomized trials, and probably it still remains one of the standards of care in the second line therapy. Next slide. So this was a pan-Asian adapted ESMO clinical guidelines for the management of patients with MGC. Next slide. This is a bit old. This has endorsed by several societies from Korea, Taiwan, Malaysia, and Singapore. Next slide. And next slide. So there it showed that for those patients with metastatic gastric cancer who are HER2 negative, which is, remember, a pretty big number. Second line, next slide. If the performance status is good, you should give paclitaxel and ramucirumab. PS2, you could give ramucirumab monotherapy or, well, a single agent chemo. 3 and 4, obviously, no treatment to be done. So this was a bit older guidelines. They have not really modified it. Next slide. The NCCN also still keeps this as one of the options. Remember, the first line, there shouldn't be any use of taxane. Again, we are having people who are using docetaxel and paclitaxel in the first line or a triplet. No real huge difference in terms of outcome. It's probably better to keep it for later and use your fluoropyrimidine and a platinum upfront. That is probably the way to go forward. Next slide. And in the second line, still category 1 remains Ramu and Pacli. And interestingly, again, this is something I want to emphasize. Again, in our practice, we are seeing this. We do get patients in second line and we are tempted. With all the kind of data in the first line, should we push for a Pembro or a Nivo in the second line? Let me tell you, there's no data for it as of now, except if you're talking of an MSI high or a deficient MMR. So second line still remains ramucirumab probably. Next line. So that was my presentation, and I would probably hand over next to Dr. Dattatreya for a case discussion.
Thank you so much, Vamshi. As usual, very important and educative takeaways. With that, now let me go ahead with the case-based discussion. And with that, I actually have two experts with me to help me in this patient's journey. Dr. Satish is a consultant medical oncologist from the HCG Hospital and the Spandana Oncology Center in Bangalore. And Dr. Nirni is my senior and a very dear friend of mine, a senior consultant medical oncologist and BMT transplanter from the Omega Hospitals in Banjara Hills. A warm welcome to both of you, Satish sir and Nirni sir. So are both of you there?
Yeah.
Yes. Hello, Nirni sir. Hello, Satish.
Hello, good evening, sir. Yes.
Yeah, good evening. So we'll talk about a male who is around 71 years now, who smoked for 40 years and quit smoking in 2010, is hypertensive, has hyperlipidemia and GERD as well. It was in November 2017 when he had dysphagia to solids, and upper GI showed a tumor in the GE junction, and the biopsy report came as adenocarcinoma. A CT scans as part of the metastatic workup did not show distant metastasis. And it was in December, no, that's a wrong year there, it's December 2017, when he underwent a IOR livis esophagectomy. And the pathology report showed adenocarcinoma grade 2 T3N0 LVI present. And for some reason, the HER2 new was, and it showed IHC1+, so HER2 new negative. So it becomes T3N0, it's stage 2A, adjuvant treatment, yes or no, Dr. Satish?
Yes, sir.
Would you like to give some adjuvant treatment to this patient who has T3N0 grade 2 LVI plus adenocarcinoma?
So this case, yes, sir, like I like to give a chemotherapy in this because they tend to have a recurrence chance will be there. Because lymphovascular invasion poorly differentiated will definitely node positive we're supposed to give. Even pathological T3 and lymphovascular invasion there, moderate differentiated tumor, I like to give a adjuvant chemo. So yes.
And what would that be?
See, like I'll try to have a platinum base with along with a 5FA base. Either Folfox I'll give or Capox I'll give. Like a young and fit patient is there, I'll try to go for a flat regimen. So.
Okay. Nirni sir, any comments from your side?
Definitely, I would like to give adjuvant chemotherapy because it's a T3 lesion and lymphovascular invasion present. So definitely chemo is would give chemotherapy. And I prefer oxaliplatin based chemotherapy because he's a 71 year. Either Capox or Folfox, any of this is okay.
So completely agree with both of you. This patient refused adjuvant treatment, but then as we all know, as per the standard guidelines, We talk to the pathologist and my surgical team. If it is a D2 lymph node dissection, then we end up giving only post-operative adjuvant chemotherapy. But if it is not a D2 lymph node dissection, then fluoropyrimidine-based chemotherapy and sandwich radiation therapy is practiced. Anyway, after more than a year, next slide, please. So after a year and 3 months later, in Feb 2019, a CT scan as part of follow-up showed pleural metastasis. In March 2019, with these reports, he came to us with a performance status of 1. I think Vamshi clearly showed us and Bharat too about the importance of performance status. So because the disease burden was low and therefore the performance status was unimpacted, pathology confirmed it to be again adenocarcinoma. The HER2/neu was retested and it now came as 3+. The MSI was stable, and I think repeatedly Bharat and our foreign speaker too clearly focused on the importance of looking at the CPS score. Nirni sir, in your practice, once the patient is labeled as stage 4 disease now with a distant metastasis, do you normally check for all these 3 parameters, HER2, MSI, and CPS, and do you do something more than this?
In all the patient in recurrent cases, we will do all these tests. Repeat biopsy followed by HER2/neu MSI score.
Satish, your impression about using comprehensive genomic profiling as first line?
First line I may not do, sir. Like I recheck of HER2 and MSI in a neoadjuvant adjuvant. Given actually if a metastatic site is there, I'll try to do that. And genomic NGS I'll try to do in as a academic research oriented, but not all the cases. But I'll try to explain in a second line. Definitely I'll do so.
So as Sarah Shukan also mentioned to us that the biology of disease may change over time. Next slide, please. So this patient was, and the next few slides, this patient was HER2 negative initially for whatever reason it was checked. And then 1 year and 3 months later, the tumor is heterogeneous. And now you end up having a HER2/neu positive disease. So those are all the distant metastatic sites there. Next slide, please. And this is the PET scan report showing that now you have confirmed a disease burden because the disease burden has been less. Fortunately, it did not impact the ECOG performance status. Now, what would you, with the information we have, its MSI stable, its CPS score of less than 5, and we know that it's HER2 3+. So you would choose any of these 4 options: platinum, capecitabine, trastuzumab, and the platinum there, Divya clearly mentioned, he always prefers oxaliplatin versus platin. What about adding pembrolizumab in the first line setting? And finally, what about using FOLFOX and trastuzumab or anything else? Option A, B, C, and D. Satish, can you help me in deciding which option should I use?
Sir, like second option is one of the best option, but the only thing is the data is there for this one, like even HER2 positive, adding pembrolizumab along with the HER2 and chemo, definitely is give a good response and PFS is better. But we supposed to have a long term the data about the survival this data, sir. But only thing practical issue about the financial. If it is feasible, definitely there's one of the first option. Second option is that the platinum with fluoropyrimidine with trastuzumab. This is the second option. So,
Nirni sir, your thoughts?
Sir, in this patient, either FOLFOX or Gilead plus trastuzumab. Pembrolizumab, still I will think of, because CPS score was, if it is more than 10, definitely pembrolizumab plus trastuzumab plus Gilead is the best option. But CPS score is, I think, 1 or 2. So I prefer FOLFOX or Gilead plus trastuzumab.
As rightly mentioned by both the experts, in our clinical practice, we almost always end up using an anti-HER2 antibody like trastuzumab, and preferably we choose oxaliplatin-based regimens. But as Dr. Vamshi also showed in the presentations, that the larger proportion of patients are actually HER2 overexpression negative. Next slide. And so when it's HER2 overexpression negative, the category 1 recommendation is to use nivolumab if the CPS score is 5 or more than 5. Otherwise, more often than not, we end up choosing Folfox or Capox. Next slide, please. So this patient, as rightly both the experts said, went on to get Folfox and Herceptin. And after 6 months, a 2D echo report showed that the ejection fraction had dropped to 45% and trastuzumab was omitted. Now, Nirni sir, like we have stopped trastuzumab, 12 cycles of Folfox are reasonably good tolerance. Now, what do you do? Do you stop Folfox as well, or do you put them on, say, capecitabine, or just observe and closely watch the patient till progression happens?
So in this patient, first thing I would stop trastuzumab, and the other we can continue. There are 2-3 options. One is we can continue Folfox, or the second option is weekly trastuzumab, also an option like we use in breast cancer. Or the best option is to change the chemotherapy instead of
no. He has responded, and the response is continuing. But 12 cycles of Folfox 6 months are over, and we are now stopping trastuzumab.
Okay.
So what do we do?
Yeah, now we can.
Can we just observe?
Yeah, observe our oral capecitabine. We can continue.
Absolutely. Satish, any difference of opinion?
Sir, like the maintenance, like see the studies there till the progression we have to give the chemo, but problem is already patient is developed a neuropathy is there, and anti-HER2 therapy is supposed to continue, but the ejection fraction has dropped. Actually, that is we have to wait and we have to follow up with the 2D echo for the recovery of the ejection fraction. Meantime, I'll try to continue with the capecitabine because there is some definitely continue 5F based how we are continuing in the colorectal tumor. You can continue as a maintenance because for this patient, I don't know how it may be like if pump is there, I can continue 5F in leucovorin infusion. Otherwise, I can go for the like capecitabine is the best option is to maintain. These are the options.
So we chose to just observe because on one hand, the EF fell to 45%.
So can we request to conclude the discussion, please?
Yes, very fast. Very fast, yeah. So therefore, this patient then went on observation. Next slide, please. And then what happened was, this is the October 2019 picture. Next, after another 5 more months, again, this progression. So now what do we do? Next slide, rebiopsy for HER2 status, or as during breast cancer, continue trastuzumab and change the chemotherapy, or what about the role of ramucirumab and paclitaxel? Nirni sir?
Yeah, in this patient, because there is no point in EF is low, so there is no point in repeating biopsy and do HER2 test. So best to go for second line chemotherapy, preferably Cyramza plus paclitaxel.
Satish, what about you?
Ramucirumab and paclitaxel? 71 plus. So either single agent Cyramza is also a good option.
Absolutely.
Yes, sir. Sir, this patient, I'll try to see how the previous toxicity is resolved or not. The neuropathy is one thing, and other thing is about that ejection fraction. I think most probably that they're reversible because the trastuzumab based. If reversible, like anyway, that other drug is not available in the other than a clinical trial or is a compassion background you have to get. The best option is a single agent Cyramza, or if the neuropathy toxicity is evolved, I may combination with the like Cyramza with a weekly paclitaxel, I may try, sir.
Excellent. Both the experts clearly told us that we need to make sure that the previous side effects have resolved. After 6 months, the neuropathy had come down to grade 1, the EF had improved, but as has been rightly pointed out, using Cyramza and paclitaxel gives a median PFS of 4.5 months as second line. The median OS becomes around 9 or 9.5 months, and hardly 25% of patients have progressive disease, with around 30% of patients having partial response. Next slide. And that's what the guidelines also tell. The preferred category 1 recommendation is to use paclitaxel and ramucirumab. And if for some reason you want to avoid the chemo, you may still choose to use single agent ramucirumab as well. Next slide. So coming to the last few slides. So we start the paclitaxel ramucirumab, finish 6 cycles by October 2020, didn't want to continue. Next slide. But then we had progressive disease. We had good response. Next slide. But only to end up with intractable vomitings. And unfortunately, Uncommonly though, you had brain metastasis, and we lost this patient after receiving palliative whole brain RT. Next slide and the next slide. So first line treatment is not the last line of treatment. Sequencing of treatments is important. You should look at the performance status, and ramucirumab and paclitaxel is a standard recommendation for patients of advanced gastric cancer, adenocarcinoma, who have disease progression of prior platinum and fluoropyrimidine-based chemotherapy. You choose the right patient for offering immunotherapy. So with that, I think we come to the conclusion of this symposium from Eli Lilly, strongly emphasizing, and as Dr. Vamshi also clearly pointed out, the importance of reserving taxanes for second line so that you can always combine Cyrams with paclitaxel and use the immuno-oncology molecules wisely, either in first line or in third line, so that ramucirumab-based treatment sticks to second line. Thank you so much, Satish and Nirni sir. I would now invite Dr. Viraj Lavingya, who is a consultant in medical oncology from the GIcancers in Ahmedabad, with special interest or with a passion towards the GI medical oncology. Having listened to Prasad Narayanan and then our foreign speaker for today, he will now summarize the role of immune checkpoint inhibitors in first-line gastric cancer, in GE junction cancer, and esophageal adenocarcinoma. Viraj, over to you.
Thank you. Thank you, Dattatreya sir, for having me here. Today is a day of immunotherapy in gastroesophageal cancers. We already had 3 speakers speak before me on the same topic. So we'll try and summarize the take-home messages today. Just a disclaimer, this is a sponsored event and the slides are given by BMS. Next slide. So today's job is to discuss checkpoint blockade first line in gastroesophageal cancers. Just a background for the residents we have here is upper GI cancers can be divided into 3 categories based on the anatomy. Esophageal cancers, gastric cancers, and the middle ones are the gastroesophageal cancers. All of these 3 have different etiologies as well as different molecular profiling, and they behave slightly different, although in the trials they are often clubbed together. Next slide. So if we see the incidence or prevalence in India, it is 6th leading cause of cancer incidence each. But if you combine them both, it is more than 1.2 lakh new cases every year. That is a lot of cases, especially in the south part of our country. Next. And if you see about 30% of cases, they get diagnosed in the late stages, and about 50 to 60% of them get diagnosed in loco-regional stages, by which you do surgery, radiotherapy, and chemotherapy, a multimodality therapy. Next. So talking about advanced disease, patients who come or present with a newly diagnosed de novo metastatic disease, or patients who have recurrence after their curative surgery or radiotherapy, the way to approach them, what Dr. Sana also said, is nowadays you have to do PD-L1, HER2, and MMR, or MSI by PCR or MMR by IHC. So it's like any breast cancer today, if you treat them without ER, PR, HER2, that's not a standard of care. So similarly, upper GI adenocarcinomas need to have HER2 by IHC, MMR by IHC, or MSI by PCR, and PD-L1 testing. Now, a little bit about PD-L1 testing. All of the speakers did speak about the testing of TPS and CPS. Remember, in lung cancer and in other malignancies, we use more of TPS, while in GI cancers, we use CPS. And CPS, as we know, it is the PD-L1 of the tumor, as well as the immune cells in the macrophages and other neutrophils. So remember, in upper GI cancers, we always order CPS and not the TPS. Next slide. Now we know immunotherapy in general, and especially nivolumab, How do they work? There are PD-1 receptors on the T cells and the PD-L1 ligands on the tumor cells. When they combine to each other, the tumor cell suppresses the T cell. That is how the tumor cells evade the immune response. And what nivolumab does, or any checkpoint blockade does, is removes this cohesion between PD-1 and PD-L1, and that's how it helps unleash the immune milieu in the patients, and that can take care of the tumor. So it is not direct tumoricidal. It helps our immune system unleash and go behind the tumor cells. Next. So with this background, we want to focus on Checkmate 649. Checkmate 649, next slide, is the largest trial till date today done for checkpoint blockade in first line in newly diagnosed upper GI adenocarcinomas. So you could see that around 1,600 patients were there, all first line with HER2 negative disease, and they were either randomized to get FOLFOX or CAPOX. They were either randomized to get FOLFOX or CAPOX plus nivolumab versus FOLFOX or CAPOX. Now, we always, before this trial, we used to do Pembro 3 weekly and Nivo 2 weekly. But in this scenario, you could do 3 weekly nivolumab if you just up the dose. So 240 for 2 weeks and 360 for 3 weeks. And the primary endpoint of this study was overall survival and PFS only for CPS more than 5. And for all comers, it was a secondary endpoint, overall survival and PFS. And also there were safety and quality of life assessments, as is common with any new studies nowadays. Now, this study was very similar to the Attraction 4 study. The only difference was this was more of a global study where it was Asia, United States, and rest of the world, while Attraction 4 was Asia only. Next slide. And the statistics were very well, because of the large number of patients, the statistics were very stringent. As you can see, the alpha of 0.02, normally we have 0.05. So again, very stringent statistical analysis were used for this trial. Next. If we see the baseline characteristics, the left 2 columns are for patients with CPS more than 5, and the right 2 columns are for all comers. You can see that about 70% of the cases were gastric cancer, and about 30% of cases were either esophageal cancers or GE junction cancers. Now, when the trial started, they took TPS as the pre-specified division, but later on, when they realized that in upper GI cancers, TPS is essentially a useless biomarker, they changed it to CPS. Nevertheless, you could see that 75%, means 3/4 of the patients had TPS less than 1. But if you see CPS more than 5, 60% of them were high. So what does this tell you? That in upper GI cancers, although the tumors may not express PD-L1, but the immune cells do a lot of times express PD-L1 staining. And hence, again, I cannot stress more that we have to do a CPS score, typically the DACO kit, what is used by Pembro and Nivo. 22C3 is for Pembro and 28.8 for Nivo. Next, please. And again, the baseline characteristic showed that about 4 to 5% of cases were MSI high, rest 95% were MSS. Equal number of patients had either FOLFOX or CAPOX. About 15% of them had a poor prognostic marker in form of signet ring cell carcinoma, and they were well balanced. Next. So this is the primary endpoint, and this is the take-home slide we want everyone to take today, that for overall survival, you could see that the median OS was 14.4 months. Finally, we crossed the 1-year mark. In gastroesophageal cancers, it was difficult to cross the 1-year mark, while in the placebo arm, it was 11.1. So that is 3.3 months median OS benefit. As it with any immunotherapy studies, when you see just median, they are not very impressive, 1 month, 2 months, 3 months. But the most important things are the landmark analysis. And if you see the patients who survive at end of 2 years, 31%. That is like every 1 out of your 3 patients who have CPS more than 5 is going to be alive with this strategy as compared to just 18 to 19%. Now, for me, this is the single most important selling point of any checkpoint blockade, nivolumab in this case. Next slide. And if we see progression-free survival, that was also improved from 6.1 months in placebo arm to 8.1 months. Again, 2 months might not seem more, but landmark analysis is important. At 2 years, 10% are not progressing on chemo versus 20% are not progressing on chemo. So that is double number of patients. You are keeping them disease-free at end of 2 years. So that is something very important to take home. You can see the right columns are all randomized patients. The gap between, although it is statistically significant, but the gap is not as large as CPS more than 5. And like Dr. Bharat said, the whole trial was mainly carried, the benefit was carried by CPS more than 5. Next slide. And so OS was better, PFS was better, and of course, even the response rates was better. So if you have a patients with bulky disease and need an immediate response, you could see far more higher complete response rates and higher partial response rates with these newer checkpoint blockades, nivolumab in this case. And most important is the duration of response. Again, common with kidney cancer, lung cancer. If your patient is responding, this patient is likely to respond for a longer time, unlike chemotherapy, which has a definite response time. Next slide. MSI high is always a very, very important biomarker because I call it like winning a lottery ticket. I heard in chat box Dr. Vamshi mentioning in 30 patients, he did not find a single MSI high. It is rare, I agree, 3 to 4% only, but these are the patients you can potentially, quote unquote, almost cure them. And the same results were seen in the Pembro trial of Keynote 62, and it was so reassuring that Checkmate 649 also shows the same signal that if you give checkpoint blockade in MSI high, the overall survival is 38 months versus 12 months in chemotherapy. I don't know even maths, this is 3 to 4 times more OS. So it's a no-brainer. If you have MSI high, checkpoint blockade is way to go. Next slide. If you see the pre-specified groups which was shown in the study, all the pre-specified groups had a benefit, whether it was gastric cancer or esophageal cancer, whether it was Asian, whether it was European. Next slide. Having said that, the tumor PDL1, you could see that if it is less than 1, the benefit is there, but benefit is little. And you could see the tumor PDL1 more than 1 is showing a lot of benefit. Next slide. Now, the authors must be congratulated in showing the results in its authenticity. Although CPS more than 1 also showed benefit, but it was very important to see what happened between CPS between 1 to 5, because more than 1 also included more than 5. And between 1 to 5, the benefit was not there. The hazard ratio was 0.94. And there was no improvement in either PFS or overall survival in this cohort. Next slide. The response rate also mimicked what I showed before, that if only you have CPS more than 5, the CR rates are 12%, versus if it is less, it is 5 to 6%. So essentially telling us that CPS more than 5 is the cutoff and a take-home message from this study. Next slide. A majority of patients had discontinued that treatment at the end of 2 years. It was a 2-year follow-up. Having said that, about 8 to 10% of patients were still ongoing on the treatment and they stopped because they finished their 2 years of treatment. Now, that is something very important, and I call them the lottery winners. Next slide. Another important point in this trial and the difference between Checkmate 649 and Attraction 4 is the number of patients who get subsequent therapies in the placebo arm. So as you can see, only 40% of patients got any subsequent therapy. That means if you see a new patient tomorrow and give them first line, 60% will drop off and never get a second line. That is not something what we have in at least expert centers. Our patients do get second line, third line, and even fourth line, some patients. So this trial is not very representative of that. Also, if you see out of those 40 patients, only 8% got any immunotherapy in subsequent lines. And in Attraction 4, that number was 40%. And understandably so, in Asia, because of Attraction 2, nivolumab was approved in those countries. And hence, when patients of placebo, when they progressed, they were given a second line nivolumab. And probably because of that, Attraction 4 failed to show any overall survival benefit, while Checkmate 649 got a survival benefit. Next slide. The safety signals were common, as we see with any nivolumab study, although slightly more death rates to my liking, 4 deaths versus 16 deaths because of treatment, something very important. And we all have learned over last 5 years how to manage toxicity with checkpoint blockade, and this strategy is no different. Next slide. And the common toxicities are mainly endocrine and gastrohepatic. Pulmonary toxicities, thankfully, so are not very common, less than 2%. And very interestingly, even rash is not a major problem. The grade 3-4 rash, which was common during the melanoma studies. Next slide. Another important endpoint of Checkmate 649 was the quality of life assessment. And all these patients were given the FACT questionnaire, and they were asked that by taking extra nivolumab, are you worried? And the answer they had to give was not at all, or a very little, or somewhat, quite a bit, very much like that. So if you see the blue color, the dark blue and the medium blue, almost 70% of them answered that they were not at all or a very little bit bothered because of the treatment they were undergoing. And that was same with chemotherapy. So it is very reassuring that by adding a checkpoint blockade to an existing chemotherapy, we are not causing more trouble, or by their language, we are not bothering them. Next slide. And they use the whole gamut of quality of life questionnaires, the GACS, EQ5D, EQVAS, and all of these quality of life questionnaires showed the same thing, that quality actually improves a little bit, although not statistically significant. But an important thing to understand is that at least by adding a treatment to an existing treatment, we are not harming them or not causing them problem. Next slide. So again, the same thing, by adding a nivolumab, we are decreasing the risk of symptom deterioration, and which is obvious because we are delaying the progression and we are making them live long. So it is but obvious that their symptoms reoccurrence is also delayed. Next slide. And this is just a tabular form of all the quality of life scores. And you could see in the sky blue, they are better, and the gray is not better. Next slide. So based on this, Opdita has got an approval from the Indian agencies for all new esophageal adenocarcinomas or gastroesophageal cancers or gastric cancer, all comers newly diagnosed. Having said that, like Dr. Bharat also showed, this approval is like an FDA, which is for all comers. But if we see in detail, the EMA has only approved for CPS more than 5. And that is what I do in my practice. If CPS is more than 5, I definitely use it first line. Otherwise, I reserve it for subsequent lines based on Attraction 2. Next line. And again, this is reiterating that if you are using Folfox, you could do 240 once every 2 weeks. And if you're doing Kpox, you could do 360 once every 3 weeks. And the maximum duration is 2 years. again, similar to any other checkpoint blockade trial. Next slide. So to summarize, Opdita or nivolumab is the first drug to show any survival advantage of PFS and OS in combination with chemotherapy in first-line gastroesophageal adenocarcinomas. Remember, pembrolizumab was a negative study in Keynote 62, and so was avelumab in Javelin. So we don't know why nivolumab is the only one showing positivity. Nevertheless, it is something we all can use. There were no new safety signals, and the quality of life were maintained. Longer follow-up reassured us that the overall survival benefit was continued throughout. With that, I thank you for your patient listening.
Absolutely fantastic, Viraj. A very nice overview of the entire trial and the important takeaways given eloquently by you. I just thought I'll ask you one question, which is like, why do all these immuno-oncology trials stop the immuno-oncology molecules at 24 months or at 2 years, or at cost like say Keytruda is 35 cycles, and the trial you mentioned had stopped at 24 months. Why don't we continue it afterwards?
So I have a different take on it. Why don't we stop early? So it is common for all cancers, in lung cancer, in kidney cancer, in melanoma. I think this number is very, very arbitrary. There is no science behind it. The trials of shorter duration of checkpoint blockades are being conducted by the ECOG, and of course they won't be pharma sponsored, but the community is trying to study that. We know, and we all have these experiences, patients taking just 4 cycles, 6 cycles, having complete response, and they are just on and on and on forever, even though you stop. So the real question is not to why are we stopping at 2 years? The real question is, can we stop early? And I think so. When the cooperative groups does these studies, we should have answers. I do stop in my practice in 6 months in so many patients, of course, because of the financial toxicity. But these are the patients who do very well, right? Even you have these patients of lung cancer and kidney cancer.
Yeah, more importantly, it opens up an avenue to re-challenge them when progression happens after a defined period of time. Yeah. Thank you so much, Viraj. That was fantastic.
Thank you.
Allowed to listen to you as usual. We now call upon to start our second session for today on pancreatic cancer and periampullary cancer. Anant Ramaswamy is an associate professor in the Department of Medical Oncology at the Tata Memorial Center in Mumbai. And he'll help us in moderating the panel discussion on adjuvant strategies in resected periampullary cancer. Anant was also, like Bharat and Viraj, the scientific committee in this entire 2-day symposium on the updates and the changing outcomes in GI cancers. Anant, would you also call upon your panelists?
Yes. Thank you, Anant. Thank you. So can I just share my slides, please? Can I just share my slides? Yeah. Am I audible, Dr. Dattatreya?
Yes, please go ahead.
So good evening, everyone. I'd like to invite my panelists. We have a good combination of surgeons and medical oncologists here. We have Dr. Kripa from Hyderabad, Dr. Rakesh from Vizag, Dr. Krupa Shankar from Coimbatore, Dr. Anjana from Vellore, and Dr. Vikram, who's my colleague from Tata Memorial. Are they all there?
Yes, sir.
Yes, great. So we have around 20 minutes for this. So the reason why this is just a basic on periampullary, the reason why we decided to have this topic is that it's not very commonly discussed. We always talk of pancreatic cancers, but periampullary cancers are not commonly discussed. So we thought we'll have this session. And one of the reasons is that this is data from Tata Memorial, published around 7-8 years back. In that, a majority of our pancreatic resections are actually periampullary tumors, not pancreas. So for whatever reason, we do tend to get a predominance of periampullary tumors for resection as opposed to pancreatic cancers. So we are in a kind of unique position to look at these tumors as compared to other parts of the world where, it is not as common. So I'll start off with the surgical aspect, Dr. Vikram. So purely from a surgical technical point of view, what are the differences in the surgical aspects of operating a periampullary and ampullary cancers? In maybe a couple of minutes, if you could just explain for the audience.
Okay, so the defined surgery. So basically, the region of origin is common. So anything which is within a centimeter of a ampullary complex, or occasionally even 2 centimeters of ampullary complex, is considered a periampullary tumor. And even a pancreatic head cancer sometimes is a periampullary tumor. However, if you consider them as 2 different entities, the surgical approach to these or the basic surgery which is required for this is same, which is a pancreatic or duodenectomy, or the resection of the pancreatic and duodenal complex. So, but definitely, as the pancreatic cancers have a higher incidence of vascular invasions and the incidence of perineural invasion and the invasion of the lymphatic structures around the SMA and the celiac is higher, the approach in pancreatic cancer, I would say, is more radical. This has been more properly elucidated by the paper by Inu's group in Annals of Surgery, where they have defined different levels of dissection around the SMA for a periampullary cancer and a pancreatic cancer. So a level 3 dissection is something which is considered for a patient who has a borderline resectable pancreatic cancer or a pancreatic cancer which is reaching the vessels. A level 1 or level 2 dissection is something which is a peri-SMA dissection. The level 3 dissection is a subadventitial dissection or immediate peri-adventitial dissection, which is done for a pancreatic cancer. And a level 1 or a level 2 dissection would be done for a duodenal tumor or an ampullary tumor. So there is a difference in surgery as far as the radicality is concerned. The lymph node stations are defined same for the pancreatic and periampullary tumors. And for a standard lymphadenectomy, for a pancreatic or a periampullary resection would be same. So there is no difference in the lymphadenectomy. However, as far as the extent of the radicality around the vessels is concerned, there is definite difference between the pancreatic and the periampullary cancer.
I think that was short and sweet. The take home from that is that vascular involvement is more. So the extent of vascular resections are more, and hence the radicality of the surgery differs. And I think, yeah, so that's a take home. Great. So we'll start with the case and then take it from there. We have a 46-year-old who had presented with jaundice. He was PS1 with no evidence of cholangitis. His bili was 9. A pancreatic protocol CT showed an ampullary growth with dilated intrahepatic biliary radicals. His surgery was delayed by a couple of weeks, so we took a call that we'll do a gram and a PTPD that showed a type 1 block. So post drainage, he was fit for surgery and underwent, as Vikram had mentioned, triple PD. There was no intraoperative or distant mets. So Vikram, what is the usual recovery period post surgery in terms of when you can refer to us as medical oncologists?
So as we all know, the Whipple procedure is associated with a significant morbidity rate and also a mortality rate, which is on a higher side as compared to many other intraabdominal surgeries. However, for any center which is a high volume center, the morbidity and mortality rate is around 2 to 4%, and the major morbidity rate around 15 to 20%. So barring these patients, most of the patients would recover around 8 to 10 days after the surgery, and they would be usually fit for adjuvant chemotherapy 3 weeks from surgery, date of surgery. So for around 75% of the patients would be fit 3 weeks from the date of surgery. Around 25% of the patients, you would see a delay of a very variable time depending upon the extent of complications. Having said that, we all know that after a Whipple procedure, almost, if not more, at least 30% of the patients do not undergo adjuvant therapy for various reasons. And not only the morbidity associated with surgery, but also the reduction in the performance status which happens with this major surgery causes that effect. So these are the things which we should be aware of. But for a normal patient who recovers normally, patient should be fit for chemotherapy within 3 weeks, by the end of 3 weeks.
Great. So ballpark would be 3 to 4 weeks is what I'm getting. Yeah. Okay. So now that the surgical aspects aside, I'll concentrate on the adjuvant aspects. So his final HPR revealed a moderately differentiated adeno-CA. It was T3A, 2 nodes involved, margins negative. I'll start with Dr. Anjana. Is there any other information that you would like from a pathological perspective before you think or not think of planning adjuvant for this patient?
I mean, I would definitely want to know what type it is, because often what happens with these is that you really don't know where the epicenter of the tumor is, and it would definitely be useful if you knew whether it is like a intestinal versus a pancreaticobiliary type or anything else. So I mean that would help, and maybe you could do a couple of IHCs if morphology was doubtful. You could also do IHC for CDX2 and MUC1. That's about it. Yeah.
Okay. Dr. Kripa, anything that you would like beyond this?
No, so I would like to see the intestinal type or pancreaticobiliary type. That's it. So accordingly, I'll plan for the adjuvant therapy.
Okay, great. So I agree with both of you. I think identifying the epicenter of the tumor and, if we had the wherewithal, look at whether it is intestinal or pancreaticobiliary type. So yes, I agree with that. So I'll go to Dr. Rakesh. Do you routinely subtype IT and PB in clinical practice?
In a single word, yes, but it is more complicated than a single word, because the way center I practice, we do get patients who are operated outside. Pathology reports comes from outside, so a lot of variation. So we don't exactly end up getting an information about the proper epicenter. So taking into consideration that the data is varied, but I would still want to know whether it is intestinal type or pancreaticobiliary type, because I believe that it does make at least have a prognostic information, if not a predictive information.
Yeah, okay. So that is good to hear that you routinely subtype it, because I think a lot of centers are now beginning to do that, across the country. We weren't doing it till some time back, but over the last 3 years or so, we are now trying and doing it. And this is a basic differentiation on, how we differentiate between IT and PB subtypes. The classical CK20 CDX2 is what we normally use, along with CK7. MUC1 also helps in case we have doubts, it looks like. Great. So the data that I could gather based on the subtyping is that IT subtypes appear to be commoner. They may have better survival outcomes, even though there is contradictory data for this. IT is treated like colon, PB, possibly like, pancreaticobiliary. Again, vastly differing data is what I could gather. This is data from our institute, which we had published around a couple of years back on more than 200 patients, where we treated all our patients with gemcitabine. We actually found that there was a 50-50% of IT and PB. It was 110 and 104. And both subtypes seem to benefit from adjuvant gemcitabine. But there was no difference in outcomes between the two subtypes, although there are other data sets which have shown that there is difference. Great. So the next part is, how do you treat these patients, in terms of adjuvant, and what are the factors that you consider? Dr. Anjana, what do you, take into account?
I think in terms of what I would consider, the first thing I would look at is the nodal status, whether it's node positive or node negative. And then maybe if it's node negative, then I would probably look at the T state if you have a node negative, then it would matter whether it's like a T1 or a T2 or a T3 or a T4. But if it's node positive, then you definitely know. I mean, in a nutshell, that's one thing which is important. And then, of course, the particular subtype, I would make, like you said, we may lean towards particular chemotherapy regimens based on whatever subtype. So for me, these are the most important factors in terms of decision making.
Okay, Dr. Krupa Shankar, what are the factors that you use when you decide on whether to give or not?
So definitely, as you rightly put up there, Anant, I think I would agree with most of the factors that you put up there. Definitely the presence of nodal involvement or anybody with an advanced T3 or T4 lesion. And, definitely the margin status matters if you were to choose between chemoradiation versus adjuvant chemo as well. So I think those are the factors that I would take into account before, actually contemplating adjuvant therapy in this patient.
Okay. I'll take one more opinion on this. Dr. Kripa, is there any group of patients, would you say, no, I will not give adjuvant?
Early T stage, maybe no. And also one more thing I want to add here is margin status as well as nodal status. Some groups are practicing adjuvant RT. Especially PJ Chandigarh paper, it has shown margin positive people are getting benefit with adjuvant RT. But adjuvant chemo, if it is early T, I'll not give. Otherwise, I'll give to everyone, especially intestinal type as well as like both types. Intestinal type, duodenal, there is a limited data, is there duodenal ampullary. So I would tend to give adjuvant except the early T stage.
Okay. So most of you would go towards giving something, chemo, RT, something. So that's the thing I could get. Great. Okay. So for the purpose of discussion, we ended up having an ampullary tumor. It was a pancreatobiliary type and the stage was 3A. Dr. Rakesh, what would you do? And if you have any other options besides what I've written here, please go ahead.
Okay. So with this 46-year-old patient, well-controlled diabetics and hypertension, I assume that margin is negative?
Yes, margins are negative. Yeah.
So I would go for 6 months of GemCap.
Gemcitabine, capecitabine.
Yes.
Okay. Thankfully, I've written gem-based tablet. Great. Okay. Dr. Krupa Shankar, what would you do?
I think if the patient is, very good general condition, performance status is fine. I would probably pick FOLFIRINOX, FOLFIRINOX based on the, the Prodigy data, the Canadian Prodigy data. We're extrapolating that from pancreatic cancers as well, but I would definitely look at doing modified FOLFIRINOX if the patient is fit and in good performance status.
Okay, this is getting interesting. I'll take the other two persons also. Dr. Anjana, what would you do?
I agree. So for this particular patient, if there's no other contraindication, I would lean towards FOLFIRINOX. And, if he wasn't fit for it, maybe the GemCap.
Okay. And Kripa, what would you do?
I agree with Dr. Kripa Shankar and Dr. Anjana. If the patient is rightly fit, he's right candidate for FOLFIRINOX, modified FOLFIRINOX regimen.
Okay. I wasn't expecting that. So, okay, great. Fine. So this is the single largest trial on ampullary tumors, right? And it's the only randomized controlled data worth quoting. 400 patients, we all know this is the SPAC trial. On the intention to treat, there was no benefit with adjuvant chemo, right? It was 43 versus 35 months. All stages, half of them had nodal involvement, a large number were T3, T4, right? And there was no difference in OS with gemcitabine or 5-FU, right? That said, we got to just have some justification for giving adjuvant. So the subtext is that on multivariable analysis, there was some benefit for adjuvant chemo. And probably gemcitabine-based chemo was better than 5-FU in terms of survival, as well as, tolerance. This is the single largest data set. A meta-analysis, British Journal of Surgery 3 years back also said there is no difference in overall survival. It was 40% 5-year survival versus 37% whether you gave some adjuvant or not. With this data, and 3 of you said FOLFIRINOX, would you like to revisit that, or I'll start with Dr. Krupa Shankar?
So again, I'll just point out your few shortcomings of this meta-analysis as well. In fact, one of the criticisms of the meta-analysis was that a lot of patients that they did include were only T1 and T2. They did not take in a lot of patients with T3, T4 or node positive disease. And we know that the benefit or the magnitude of benefit of adjuvant therapy is much higher in those patients. That's point number one. And again, even if you look at even the earlier studies, like the URTC study, again, they did include a proportion of patients who were who had periampullary carcinomas, be it around 40 to 50%. The SPAC, like you rightly mentioned, is probably the single data. But if you go by it, then probably you shouldn't be offering adjuvant therapy at all, because the overall intention to treat population did not benefit. So we have to agree and admit that we're going to extrapolate data from the pancreatic cancer subset. So that's why I would probably still stick to my guns and say yes. The Prodigy data for me is good enough. 54 versus 35 months, an absolute improvement of 19 months improvement in overall survival. So if somebody's fit, like Anjana said, definitely FOLFIRINOX. Not fit, then gem-based regimen.
Okay, Dr. Rakesh. By the way, Dr. Krupashankar, I completely agree with you. I think, I just wanted to point it out that, it's a rare tumor. Whatever we're going to get is from extrapolation, so I kind of agree with you that, plus this was older data. Things have changed over the last some time. Dr. Rakesh, your take on that?
Yes. So it's a confusing subset actually, periampullary, and I'm glad that this has come up for discussion with such peer group. So I would say that my takeaway from SPAC3, you rightly mentioned that this is the single largest and cleanest, probably the cleanest trial that comes across for periampullary. And my takeaway from that is patients need adjuvant therapy. There is a problem with the ITT analysis. We all know that. And ultimately, the takeaway is that adjuvant chemotherapy benefits. To do gemcitabine alone versus something like SPAC4 GemCap versus something like Prodigy, I would say that when we are incorporating this histomorphological data, again it becomes ambiguous, and whether intestinal benefits or pancreaticobiliary benefits. And if a patient is showing pancreaticobiliary phenotype, I would say that gemcitabine alone probably it is like striking a balance between the degree of chemotherapy. Prodigy again had only pancreatic adenocarcinomas and not periampullary, and even the pancreaticobiliary type of periampullary, I think it is different from pancreatic head malignancies alone. So my take of GemCap is something like a balance between gemcitabine alone versus a more toxic regimen like FOLFIRINOX, and that's how I've come with GemCap as my what I'm practicing with for my patients.
Yeah, that makes sense. We're all extrapolating, and we used to give GEM earlier because that's what the maximum data was for. As Dr. Krupashankar said, if we went purely by SPAC, then we should not be offering adjuvant, and that is possibly a disservice to the higher T and N stage tumors, So yeah, I get your point, right. Is there any part of your treatment that includes radiotherapy? Kripa, do you ever consider?
Yes.
Okay. And when?
No, so it's not actually, no, sir. Usually margin positive, there is some data regarding usage of RT. SPAC4 as well as SPAC3 both has good number of R1 positive as well as node positive patients. But actually they did quite well with chemotherapy alone. Only I'm not so far for giving RT adjuvant setting.
Okay. Margin positive has been since the last 20 years. Whenever we've been taught margin positive means you give RT, benefit or not, evidence or not, that's the way we do it. Dr. Anjana, any thoughts on that?
Yeah, actually at our center also we don't offer RT. We just are on the side of just giving the adjuvant.
Yeah, I think if you are going to think of this as a pancreatic tumor, then RT is out. World over, everyone's moving away from RT. So likely you will not give, but sure. This is the one data set that, is now ideally is 2 decades old, so we should not be discussing it. The problem is that this is the best existing prospective RCT for RT. 218 patients, and they showed that there was no benefit with adjuvant RT. But again, old techniques, they used to give a weird schedule of 5U, but it is what it is. This is the data available. Just to round up, specific guidelines do not exist for ampullary tumors. There are even lesser recommendations for adjuvant. Most suggestions, as all of you had said, think of it as a pancreatic tumor. The European and the Japanese think of chemo alone. It's only the US which says consider RT. So, because of the lack of data and guidelines, it's anyone's pitch. You could treat based on what your institution likes. This is what we do at TMH, since we are a high volume center, and Vikram and his colleagues operate a lot of these tumors. With less than equal to T2 and node negative, we observe. T2 and above or node positive, we consider treatment. Generally, we consider RT only when there is margin resection positivity. There's a trial that I'm heading along with my colleagues where we are treating based on histology. All our ampullary tumors are subtyped into pancreaticobiliary and intestinal type, and we are comparing it to historical controls. to see whether it improves survival or not. So the sample size is around 190, and we have reached around 67 patients over 1 year, 1.5 years. So maybe 4-5 years down the line, we'll have something. This is data that Dr. Vikram and me have collected from across the country. 1,200 ampullary cancers. We had sent out, a request to these centers, and thankfully, a lot of centers collaborated with us on this, and this is being analyzed as we speak, and hopefully, we'll have some Indian data on this. I think with that, I'm going to wrap up. I'd like to thank the panelists and everyone for your kind attention. Thank you so much.
Thank you so for the excellent discussion.
Thank you so much, Anant, and all your esteemed panelists. I think one of the topics which is not commonly discussed, but was elegantly brought out by all of you. And I think it generates interest among all of us that we all need to keep on reviewing literature so that sometimes it's extrapolation as well, as was rightly by all of you pointed out. Now, with that, we now go on to the last part of today's talk, and Dr. Vikram Chaudhary, who is professor of the Department of Surgical Oncology in TMC Mumbai, and also is the consultant in the GI and the Hepatico-Pancreatico-Biliary Surgical Oncology Unit, will deliver the keynote lecture for today. And that's evidence-based multidiscipline treatment of borderline resectable pancreatic tumors. We all talk about adjuvant treatment of CA pancreas. And of course, we all talk about neoadjuvant treatment, how to approach resectable pancreatic cancer, but borderline. Thank you so much, Vikram sir. Over to you. Vikram sir.
Yes, my slides are visible. Hello.
Absolutely, and we can hear you very well.
Okay, so I thank the organizers, Viraj, Anand, Dr. Dattatray, and everyone, and Dr. Bharat for having invited me. I appreciate that you invited a surgeon to this a meeting, which is predominantly a medical oncology meeting. And probably this underscores the importance of a multidisciplinary management of borderline resectable pancreatic cancer. Greetings from Tata Memorial. And so let's define it. There are anatomical criteria which define borderline resectable pancreatic cancer. There is a venous criteria, there is an arterial criteria. And among the veins, if the porto-splenic or porto-SMB confluence reconstruction is possible, that kind of involvement, irrespective of the extent of involvement, is defined as borderline resectable. As far as the arteries are concerned, if the extent of involvement is less than 180 around the celiac and the SMA, that is also defined as borderline resectable. The hepatic artery, less than 2 centimeter involvement near origin of GDA, without any extension to the celiac trunk, is also anatomically defined as a borderline resectable pancreatic cancer. There are various definitions proposed by various groups. However, most of the definitions have this common theme of anatomic definition, which is almost similar. As far as the NCCN is concerned, there is slight difference in the definition, where the celiac artery involvement in the distal or the body tail pancreatic tumor is also defined as borderline resectable pancreatic cancer, as long as it is resectable by a modified Appleby procedure. So that's the only difference. Now, in order to widen the definition or include more number of patients or prognosticate them properly, the International Study Group of Pancreatic Surgeons proposed a broader definition of borderline resectable pancreatic cancers, where they propose that there are patients who have higher CA19-9 levels, usually more than 500, and the patients who have poor performance status, which probably precludes a major surgery. And even if their anatomical criteria suggest that they are resectable, probably they also need to be included in the borderline resectable subgroup. However, I must say that this definition is not universally followed and acceptable, but this is something which is worth considering in prognosticating the patients with anatomical criteria where there is a resectable pancreatic cancer. We all know that the adjuvant chemotherapy works in pancreatic cancer. With each passing trial, the median overall survival increased from 20 months to almost 28 months, and 5-year overall survival reached to 29 months till the PRODIS data came, which actually took it very high. And with FOLFIRINOX, we reached a median overall survival of 54 months. And therefore, we know that the adjuvant chemotherapy definitely helps. Another important factor to consider in effectiveness of adjuvant chemotherapy is that we know that the adjuvant chemotherapy helps to the proportion of the number of cycles the patient completes after surgery. So if you complete more cycles, the survival will be proportionate to the number of cycles. So we know that. And therefore, but however, the clinical reality I just mentioned in the previous Anand's panel discussion, that we all know that the Whipple's is a procedure which is associated with very high morbidity and mortality. So almost 1/3 of the patients fail to receive adjuvant therapy due to postoperative complications, early metastasis, reduced performance status, and sometimes comorbidities which preclude a full intensity chemotherapy. And therefore, and there are other issues in borderline resectable pancreatic cancer. The intimate relationship of the tumor with the vessels means that there is a significant proportion of patients do undergo margin positive resection, which may impart them poorer outcome and survival. There is increased complexity of surgery, which involves vascular resection in BRPC, and which also is associated with slightly higher morbidity and mortality as compared to resectable pancreatic cancers or the Whipple for other indications. And there is an increased risk of radiologically occult distant metastasis. The chances of these being present is higher in patients who have borderline resectable pancreatic cancer. And therefore, there are arguments or hypotheses in favor of neoadjuvant therapy, that the neoadjuvant therapy gives better chances of therapy completion. It might provide a better biologic selection. It might downstage a significant proportion of patients, and which can give us more margin negative resection, which may translate into improved survival. And early administration of systemic therapy in this kind of systemic disease is also supposed to help. So let's check whether the evidence supports this hypothesis or arguments. We all know that a certain proportion or a significant proportion of patients who are administered neoadjuvant chemotherapy in resectable or borderline resectable pancreatic cancers do progress. The average rate is around 25%, but the studies which I'm going to quote in the remaining presentation, you will see that the rate varies from 25 to almost 50 to 60%. So the progression rate with neoadjuvant chemotherapy is in the range of 25 to 50%, and therefore a certain proportion of patients will lose their opportunity to undergo surgery. So is it a better biological selection, or is it a loss of opportunity to few patients? You see that early recurrence post-surgery happens in 20% of the patients. So you can see that the 20% of the patients have already died within first year of surgery in those patients. And if you compare the patients who progress, so these are the patients probably who will be selected or who will drop out on neoadjuvant therapy. So early recurrence rate after surgery is similar to the patients who progress on neoadjuvant therapy, and therefore this argument probably goes in favor of neoadjuvant therapy, that probably these patients who are likely to recur very early after surgery are going to be dropping out after and maybe probably we can avoid a futile surgery. But exactly if it is going to happen in the same subset of patients, we have no criteria to find it out. And that's the problem. However, percentage wise, this looks similar, that 20 to 25% patients will progress on early after surgery, and 20 to 25% of the patients will not undergo surgery. So this is matching and probably acceptable. So more R0 resections following neoadjuvant therapy, does it happen? Yes. In fact, a lot of locally advanced pancreatic cancers who are deemed inoperable, a third of these patients might become operable after a successful neoadjuvant chemotherapy. Now we were discussing what happens if the margin is positive. So we must first understand that whether resectable or borderline resectable, most pancreatic resections are R1. So this is a fact. So since the advent or the adoption of a Leeds protocol, where the circumferential resection margins are assessed by the pathologist, or since the quality of margin reporting has improved, we know that 70% of the pancreatic resections are at least R1. So now the R1 is subdivided into R1 direct involvement and R1 within 1 millimeter. And we know that R0 R1 direct, and R1 within 1 millimeter all have a difference in their survival depending on the margin status. And this has been, we have also published our own data from Tata Memorial recently. And in our own practice, you can see that almost 57% of our pancreatic head cancers had margin positive resections in last decade. And I don't think we have reduced it much, but probably currently it is around 40%. And whether it transmits the reduction in the or the improvement in R0 resection with the neoadjuvant therapy is definite, but whether it transmits into the overall survival is something which needs to be proven yet. However, this trial, there are studies which have shown the benefit, and this Japanese study has also shown that with S1 and radiotherapy, probably the R0 resection rate and the median overall survival with the patients with neoadjuvant therapy and BRPC has translated into a better survival when you do a R0 resection. So when compared the R0 resections with R plus resection, they found out that the R0 resection after neoadjuvant chemotherapy definitely has an improved survival. So so now coming to the evidence in favor of borderline resectable pancreatic cancer in favor of neoadjuvant therapy. So the most commonly quoted trial is the PRIOPANC trial. We all know that, and it included 246 patients. However, there are certain issues with this trial for me. We know that it is a large trial and it is difficult to conduct a large trial with pancreatic cancer. But we all know that they combine the resectable and borderline resectable pancreatic cancer. For me, it is acceptable. But for the chemotherapy regimen which was used, the survival figures which have come out, the intensity of radiation, probably all is questionable in this trial. And in spite of all these things, you can see that the resection rate was in the neoadjuvant therapy group was only 60%. And it is also difficult to understand why only 72% of the patients underwent surgery in the upfront group, where they failed to provide any benefit or difference in the resection rate as far as two arms are concerned. There was a slight difference, though statistically significant. You can see that only a week's difference in the disease-free survival, and which also did not translate into a benefit in the overall survival as far as the overall cohort is concerned. However, on the subgroup analysis of borderline resectable patients, you can see that there was a significant or a statistically significant survival benefit in the borderline resectable subgroup. So they concluded that probably the borderline resectable subgroup is the one where the benefit is definitely proven. And you can see that the DFS benefit was not translated into overall survival benefit. Recently in ASCO, probably they presented their data and the long-term outcomes, where the whole cohort also showed benefit of neoadjuvant therapy in both the groups. So probably the PRIOPANC has conclusively told us, irrespective of the intensity of the radiation and the type of chemotherapy they used, probably neoadjuvant therapy is something which is going to help the patient. We also published our own data. This is one of the largest data from our country of borderline resectable pancreatic cancers. I published this last year or recently in surgery. So we analyzed 201 patients of borderline resectable pancreatic cancer treated over the period of last 12 years. And you can see that absolute progression rate with neoadjuvant chemotherapy was around 32%. Finally, after neoadjuvant therapy, we operated 63 patients and we operated 40 patients after in the upfront surgery arm. And this is a real world data where the patients have received FOLFIRINOX and gemcitabine-based chemotherapy and also have undergone upfront surgery after discussion in the multidisciplinary clinic. So this is a real world data. We definitely saw that the neoadjuvant therapy group had a significant response rate. They have significantly less T stage. The lymph node positivity was less, and the perineal invasion rate was significantly less in that group. It also showed a significantly higher R0 resection rate, the neoadjuvant therapy group. But you can see that on intention to treat basis, the neoadjuvant therapy group did not have a better survival as compared to upfront surgery arm. And also the DFS was not much different. However, if you compare the patients who underwent surgery, you can see that in our own data, there was a definite benefit of neoadjuvant chemotherapy. So if you can operate the patient after neoadjuvant therapy, that patient benefits. So we did not see much difference between the FOLFIRINOX and gemcitabine arms. And another interesting fact which came out from our analysis is that if you start the adjuvant therapy, if you complete the adjuvant therapy, or if you complete all arms of therapy, for each of this type of patient, the survival keeps on improving. And the highest survival was seen in the small final subgroup which received neoadjuvant therapy, underwent surgery, and completed adjuvant therapy, which also underscores the importance of neoadjuvant therapy. So finally, probably we concluded that the progression rate with neoadjuvant therapy was 32%, and probably on intention to treat basis, the neoadjuvant therapy did not provide survival benefit. However, in resected patients, it definitely shows benefit. We all know that ISPECT-5 was a 4-arm trial where the immediate surgery, GenCap, FOLFIRINOX, and CTRT was compared. Because of the four arms, probably each arm had very few patients, and the resection rate in this trial is something which probably could have been more, maybe slightly suboptimal, and the R0 resection is really suboptimal. However, this is a randomized control data and needs to be respected. You can see that the estimated 12-month survival for a neoadjuvant therapy group was significantly higher than patients who underwent upfront surgery, and definitely proving the benefit. Among the neoadjuvant therapy arms, or when you compare all the 4 arms, you can see that the FOLFIRINOX group had the highest survival, estimated highest survival at 1 year, and the lowest was with the upfront surgery. Probably this also underscores the importance of neoadjuvant therapy. Alliance trial, which was again presented in the ASCO, probably this trial has disappointed the radiation oncology colleagues, and it failed to provide any benefit of prove the benefit of SBRT. This was a well-planned trial. However, it has failed to provide show the benefit of SBRT. However, the important message which we got from the whatever data they have found out is that the neoadjuvant FOLFIRINOX was associated with a favorable overall survival relative to the historical data. And when you don't have much large trials, ultimately you have to combine the trials and probably look at the meta-analysis. And this meta-analysis from the Dutch group also showed that the neoadjuvant therapy improves overall survival in patients with borderline resectable pancreatic cancers, definitely. However, as far as the resectable pancreatic cancer group is concerned, we definitely need some more data. Now, when the patient is responding, the obvious temptation is to why not complete the neoadjuvant therapy. I think this is a perfectly acceptable principle if the patient is responding with the kind, and we all know that 1/3 of patients are not going to complete their adjuvant therapy after Whipple. This is something to look up to, and we also are looking at this approach in patients who have a good response. This is something which is going to pick up soon. And you see that the studies are coming up where we know that the total neoadjuvant therapy, we see that the downstaging effect is the best with the total neoadjuvant therapy. Finally, a word about response prediction. We know that we must accept that though the operability overall is best assessed by a CT scan is very poor as far as the response assessment is concerned after neoadjuvant therapy. And not only the biologic response in the form of response in reduction in the tumor marker levels, there is also a thought that a PET MRI or a PET CT is something which is likely to benefit you more, and the studies are coming up where the response evaluation is assessed more with a PET CT or a PET MRI. But general dictum or a general principle in these patients of borderline resectable pancreatic cancer after neoadjuvant therapy is if there is a partial response, complete response, or a stable disease, explore them. There is no excuse of not exploring them as long as they have not progressed. And to summarize, borderline resectable pancreatic cancer requires multimodality management. BRPC requires chemotherapy as the initial modality of management. FOLFIRINOX regimen should be considered when feasible. R0 resection is the key. SBRT can help maximizing the outcomes when sequenced with systemic chemotherapy and surgery, and there is a definite role in patients where the disease remains stable in a group of patients. Outcomes in BRPC are improving with multimodal treatment. Final word, however, in BRPC is yet to be written. Evidence will keep on evolving. Each approach still has a scope. Neoadjuvant chemotherapy seems to be ahead of other treatment options. and personalized treatment is the way forward. Anand just mentioned in his presentation that a significant number of our patients are actually ampullary, periampullary tumors. In last few years, the proportion of pancreatic cancers which we are treating among our peoples is increasing. We are just about 30 to 35% as far as pancreatic cancer is concerned. Around 60% are ampullary and 5 to 10% are the other pathologies. Last year, we crossed that elusive number of 200 people resections, and I'm very happy to present our data to you. Thank you. Thank you again for inviting me. Thank you.
Thank you so much, Vikram sir. That was very informative. And I think you brought out all the important issues related to the management of resectable pancreatic tumor, but of borderline, but it's borderline. I'm so glad that we could have you as our keynote lecture guy, because you did full justice and you made us realize the importance of not only the international data, but also putting our own data at an international platform. Thank you so much. And I thoroughly enjoyed every part of your talk. Thanks for enlightening all of us. Thank you so much. Not only as an esteemed panelist, but as the keynote lecture delivering by you, I think it's very prudent that all of us make sure that we pool our data and then start presenting and publishing it. Thank you, sir. Thank you very much.
Thank you. Thank you, Dr. Palan. Thank you. Thank you.
So with that, we come to the end of day one of the second changing outcomes in the sphere of GI cancers. And here, as you can see, Dr. Axel Grothi is there tomorrow. And tomorrow is the second and the final day of how we can change outcomes in the sphere of GI cancers. To summarize today, we started with the esophageal and gastric cancer in session 1, with Prasad Narayanan talking about how we can optimize the role of immune checkpoint inhibitors in advanced esophageal cancer. And then Dr. Sana Al-Sukun took us about the same in gastric cancer, and an overview of how she'll help us in guiding treating our patients in 2022 for gastric cancer. Bharat was able to very clearly elucidate 5 important abstracts from ASCO GI, and they're pretty practice changing. The session by Eli Lilly was taken over, and Dr. Vamshi Krishna was in charge, who told us about how the overview of ramucirumab has been in the entire country over the last few years. And especially important was to discuss about the real world evidences. And then we had a clinical case-based discussion on the implications of using ramucirumab and paclitaxel with 2 experts, Dr. Nirni and Satish, giving their expert comments. Dr. Viraj then spoke about immune checkpoint inhibitors in first-line gastric cancer and esophageal GI cancers. The session on pancreatic cancer and periampullary cancer was initially moderated in a very eloquent manner by Anant Ramasamy and his team of panelists. And finally, the conclusion, the icing on the cake, was to have our esteemed surgical oncology colleague who gave us an evidence-based management of involving multiple disciplines to treat and to approach borderline resectable pancreatic tumors. With that, I hand over the mic to the organizers so that they can now leave us for dinner.
So thank you so much. Thank you so much, Dr. Dattatreya sir, for coordinating this entire event so meticulously. And of course, we are absolutely bank of time. So we will not come in between you and the dinner. We profusely thank all the speakers, the moderators, the panelists, the entire faculty, all the delegates who have joined us today. Looking forward for everyone to join us tomorrow. And till then, stay safe and a very good evening to everyone. Thank you so much for joining. Good night, sir.
Thank you. Thank you. Good night.